হ্যাঁ, 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 এসছে, এসছে, এসছে। এই এসে কেটে গেল। ওহ, ওহ, ওহ! হ্যালো? এই, এখন আসলো। সেই সাথে, সাথে বললাম। ওহ! দাঁড়াও। হুম।
नहीं यार नहीं।
তুই কি ঢুকতে পেরেছিলি না পারিসনি? ও ঢুকে যা, হ্যাঁ ঢুকে যা। হ্যাঁ, এত কিছু তো আসেনি, জাস্ট সোজা চলে এলো। তো এত কিছু তো করতে হয়নি। আমার ইমেলটাতে যেখানে আছে ওখানে তো সোজা চলে এলো। ওরা একটা ইমেল পাঠিয়েছিল, তো সেই ইমেল থ্রু দিয়ে যাচ্ছিস তো? হ্যাঁ। ও আচ্ছা আচ্ছা, তাহলে হয়তো আলাদা কিছু সিস্টেম আছে, সেটা হয়তো তাহলে 6টায় ইন হবে, কি জানি। কার্তিক তো ঢুকে পড়েছে দেখছি, কার্তিক তো ঢুকে পড়েছে। কার্তিক ঢুকেছে, শীর্ষেন্দু মানে যে এই তোমার মেরিন ডে, সেও ঢুকেছে, তাহলে হয়ে যাবে। তুই একটু ওয়েট কর। হ্যালো, আচ্ছা
Hello.
রাখলাম, একটু ফোনটা রাখছি। হ্যাঁ,
Good
Can you
evening,
hear me,
sir.
guys?
Yeah. Sir, good evening.
All clear?
Welcome, sir.
Thank you very much. Shall I try and share screen just to make sure it's working?
Yeah.
just
Just a minute,
share your
sir.
screen so that we can know.
Yeah.
Just
Good
let
evening,
me know
Shishendu.
when.
Kalia, sir. Kalia, sir. सर मैं आपको बना रहा हूँ।
हाँ बना दे बना दे।
कर दिया सर। Yeah, Dr. Karthik.
Yes.
You can share your screen. You can test it because I have to give the opener's screen once again. I have stopped my screen. Yeah.
Is that working?
Yes, sir. Slide mode, please.
Are you happy with that?
Yeah. Sir, please run it. Yeah, sir. It's okay.
Okay, excellent. Thank you. I'm just going to stop sharing now. Okay?
Yeah. Yes, sir.
There we go. So we are meeting back. We're starting in about 15 minutes. Is that right?
Yeah. 15 minutes.
Okay. Well, I will join you shortly. I just want to
Okay.
do
No
something.
issue.
But you can hear me clearly, yes?
Yes, I can hear you clearly.
Excellent. Thank you very much. We'll see you shortly.
Okay, sir. Welcome.
Okay.
Corsair,
Yes,
Corsair, Corsair.
Yes.
It is live in YouTube already.
already.
আমি হ্যাঁ আমি
না, এখন
এখনো
তো রেকর্ডিং করে লাভ নেই।
আমি রেকর্ডিংটা এখনো দিইনি,
হ্যাঁ।
কারণ ইউটিউবে আমাদের টাইম লাগে।
হুম।
ইউটিউবে আমি লাইভ করে দিয়েছি,
হুম।
ঠিক আছে। রেকর্ডিংটা আরম্ভ হবার 10 মিনিট আগে দেবো, ঠিক আছে।
ঠিক আছে। একবার বেরিয়ে গিয়ে আবার ঢুকছি।
হ্যাঁ, টিজিদা শুনতে পাচ্ছ?
হুম।
হ্যাঁ, ঠিক আছে।
তুই জয়েন করেছিস, ভিডিওটা অন করিস তো?
হ্যাঁ, জয়েন করলাম।
আচ্ছা, ঠিক আছে। বাপ্পা তো জয়েন করে গেছে।
তুমি
বাপ্পাদের
একটা শুনেছো
ভিডিওটা-
নবারুণের খবরটা শুনলে?
নবান্নের কি হয়েছে? শুনি তো কিছু। হ্যালো।
নবারুণ?
হ্যালো,
হ্যাঁ, মানে আমাদের ডানকুনি
হ্যাঁ।
দুর্গাপুরের।
নবারুণ যেটা না, আমাদের যে জুনিয়র নবারুণ।
ও আচ্ছা, জুনিয়র নবান্ন। না, শুনিনি।
আরে ওর তো হাইপারটেনসিভ থ্যালামিক ইসচেমিক অ্যাটাক হয়েছে, লেফট সাইড প্যারালিসিস হয়েছে।
বাবা।
হ্যাঁ, ও
প্যারালিসিস নয়, প্যারালিসিস হয়নি।
ও তাহলে কি হয়েছে?
প্যারাপ্লেজিয়া।
প্যারাপ্লেজিয়া হয়েছে, অমর অমর
না
পোস্ট করেছিল।
আমার ভিডিওটা পজ করা আছে, কারণ হচ্ছে যে আমি মানে ইয়েতে আছি, গাড়িতে আছি।
ও পার্থদা, হ্যাঁ পার্থদা আর কিরণদা যাচ্ছে।
হ্যাঁ কিরণদা
কিরণ
গাড়ি চালাচ্ছে, আমি
কিরণদাকে ফোন করেছিলাম, কিরণদা হ্যাঁ
কোথায় আছে?
শুনলাম
মুর্শিদাবাদ মেডিকেল কলেজেই আছে, অমর দেখেছে।
বর্ধমানে আছে।
বর্ধমানে?
বর্ধমান মেডিকেল
এই
কলেজ?
মুর্শিদাবাদে আছে, বহরমপুরে।
হ্যাঁ,
এবার আমরা
বহরমপুর।
যাচ্ছি ওইখানে আর কি।
আচ্ছা।
আচ্ছা,
আমরা ওখানেই যাচ্ছি। এবার খুব বাজে একটা নিউজ আর কি, মানে আমরা যেহেতু এইদিকে ছিলাম, আমি তো রায়গঞ্জে এসেছিলাম বললাম সকালে স্যারকে।
হ্যাঁ।
তো সেই রায়গঞ্জ থেকে ফেরার পথে এটা হয়েছে শুনতে পেয়েছি। আমাকে সঙ্গে ফোন করেছে
পুরো
হচ্ছে
মানে
ওখান থেকেই আমাদের সৌরভ, এরা সব ফোন করেছিল।
না না, গিয়ে
তোমার এরা
দেখো
ফোন
যা যা
করলো,
বেস্ট
তা আমি দেখলাম
পসিবিলিটি,
যে-
বেস্ট পসিবল যা যা করার
হ্যাঁ
করতে হবে।
কি হলো ওর অ্যাকচুয়ালি?
বলছে তো হাইপারটেনসিভ। গুড ইভিনিং বাপ্পাদা।
হ্যাঁ, গুড ইভিনিং, গুড ইভিনিং, গুড ইভিনিং। তাহলে এটাকে ঠিক করি।
ঠিক আছে, আমি ভিডিওটা চালাবো না, কানেকশন খারাপ আছে, সেজন্য
ঠিক
ভিডিওটা
আছে, ঠিক
বন্ধ
আছে,
রাখবো।
হ্যাঁ, ঠিক আছে।
হ্যাঁ।
কি হয়েছে?
বাপ্পাদা মুখোশ পড়ো।
অভিজিৎ স্যার গুড ইভিনিং।
Good evening, good evening,
good
good
evening.
evening.
বাবা দাদা কেমন আছেন?
চলে যাচ্ছে।
দাদা পার্থ বলছি, কেমন আছেন?
হ্যাঁ, ভালো আছি। তোকে তো তুই ভিডিওতে নেই।
না, ভিডিওতে নেই। আমি আসলে আমাদের নবারুণ সাহা আছে না মুর্শিদাবাদে,
হ্যাঁ, জানি
বহরমপুরে,
জানি জানি জানি। বাপ্পা
ওর
ফোন
একটা
করছে।
হয়েছে।
একে একটু দেখ, বাপ্পা ফোন
হ্যাঁ।
করছে। হ্যাঁ বল।
জিজিদা,
তুই জুম ডাউনলোড
জিজিদা,
মোবাইলেই খোল। মোবাইল, হ্যাঁ
জিজিদা শুনতে পাচ্ছ?
বল।
বাপ্পাদা তোমার ওখানে তো এখন কেস বেড়ে গেছে তো।
হ্যাঁ, 200 হয়ে গেছে তো।
তবে
200
তবে আমরা খুব মানে কম্পিটিশন করছি কলকাতার সাথে। হাওড়া।
কি করবি, দেখছি তো তাই। এদের অবস্থা তো খুব সাংঘাতিক।
আরে দুটো কেস পজিটিভ, ওটির পর রাত্রিবেলা ফোন করে বলছে যে পজিটিভ এসেছে। আমরা তো রীতিমতো টেস্ট সিচুয়েশন হয়ে গেছিল। যাই হোক, সবাই ভালো আছে, পেশেন্টও ভালো আছে, বাড়ি গেছে।
এটাই আর কি, ভালো আর কি। তো পার্থ, ওই নবারুণের লেটেস্ট খবর জানিস?
এবারে আমি ফিরছিলাম বাড়িতে আর কি, আমাদের ওই রায়গঞ্জে গেছিলাম আমি আজকে, মানে কালকে গেছিলাম। তো ওটা ফেরার পথে শুনতে পাই। এবারে আমি এখন বহরমপুরে,
তুই
বহরমপুর থেকে যাচ্ছি।
রায়গঞ্জে ফিরছিস, গাড়িতে করে ফিরছিস নাকি?
গাড়িতে করে, হ্যাঁ। আমি ওইখানে রাস্তায় খবর পেয়েছি, তো আমি এখন ওই নবারুণের কাছেই যাচ্ছি বহরমপুরে।
এটা কিরকম হলো? রায়গঞ্জ থেকে মালদা হইতে যেতে হবে বহরমপুরে, শুনেছি আমি। তাই তো
আমি তো স্যার এমনি ফিরছিলাম, আমি তো একবার আপনাকে ভাবলাম যে হ্যাঁ
এটাই তো রাস্তা শুনেছি আমি। একবার একটুখানি বাপ্পাদের সাথে দেখা করে গেলেই তো হয় নাকি? 5 মিনিটের জন্য।
আমি তো এটা তো রেগুলার ইস্যু,
তা রেগুলারই বাপ্পাদাকে দেখতে পাবি, একটু নয় কি আছে।
একদম পরের সিওর। না, এবারে এই যেতে যেতে খবর পেলাম, তো এবার আমি দেখলাম যে এতটা কাছে আছি, হ্যাঁ, তো আমি চলে যাচ্ছি, আর 15 মিনিটের মধ্যে ঢুকে যাবো। আমি দেখলাম ভিডিওটা চালালে পরে নেটটা কানেকশন পাচ্ছে না, সেজন্য ভিডিওটা পজ করে রাখলাম। ভিডিওটা চালাবো না, গাড়িতে আছি। হ্যাঁ, ঢুকে তো গেছি, তারপরে আপাতত শুরু হোক, তারপরে আমি মাঝখানে হয়তো কেটে দেবো ঢুকলে ওখানে, পরে আবার জয়েন করবো। পরে আবার জয়েন করবো। হ্যাঁ, আর স্যারেরও একটা ইস্যু হয়েছে মনে হচ্ছে নেটওয়ার্কের।
জি স্যার, আমরা ব্রডকাস্টিং দিচ্ছি। বস স্যার, ব্রডকাস্টিং দিচ্ছি। বস স্যার,
হ্যাঁ ঠিক আছে,
ব্রডকাস্টিং দিচ্ছি।
হ্যাঁ,
আচ্ছা, ডক্টর কার্তিক হরিহরন জয়েন করেছে, মেসেজ করেছে।
সোমবার পাবেন।
ডক্টর হরিহরন জয়েন করেছিলেন, উনি একটু বলে গেছেন আমাকে 10-15 মিনিট বাদে আসছেন।
শিওর, ঠিক।
স্যার ব্রডকাস্টিং দিচ্ছি কিন্তু। হ্যাঁ,
লাইভ যাচ্ছে। হ্যাঁ,
গুড ইভিনিং অভিজিৎ স্যার।
গুড ইভিনিং।
ভালো আছেন তো?
এই তো ঠিক আছে সব।
Abhijit, recording, broadcasting, YouTube live started.
ওকে আমরা ছটায় স্টার্ট করবো তো
হ্যাঁ,
6টায়
হ্যাঁ।
না না এখনই শুরু করে দাও না কি আছে আবার সুযোগ তো আছে
4 মিনিট বাকি আছে।
4 মিনিট
তো লাইভ হয়ে গেছে যখন আর কি শুরু করতে অসুবিধা কোথায় আছে লাইভ হয়ে গেলে তো শুরু করাই যায় যদি অসুবিধা না থাকে আমি জানি না লোকে তো লাইভে এগুলোই দেখতে পাবে
কিছু দেবো পারমিট
আমি খুব সামান্য সামান্য জিনিসও জানি না
হ্যাঁ,
তোমার ওপেনিং স্লাইডটা তুমি শেয়ার করবে।
আমি কি শেয়ার করব?
হ্যাঁ,
দাঁড়াও, আমাকে একটু সময় দাও।
কমবে বাড়বে
সময় দেওয়া যাবে।
হ্যাঁ
ছেড়ে দাও, আমি করছি।
নিয়ে এসেছিল ওই জন্য দেখো দেখুন সেটা ওয়াইফাই কানেক্ট হবে কিনা আবার আমার ওয়াইফাই ছাড়া
ও তোর আবার ওইটা না তার নেই তো এটা বাড়বে কি করে বলবে এইটা দিয়ে এফসি তে
এই স্বর্ণেন্দু, হ্যালো স্বর্ণেন্দু,
হ্যাঁ বলো বলো
তোকে একটা ইমেল পাঠিয়েছি দেখ।
শোনা যাচ্ছে?
একটা ইমেল পাঠিয়েছি দেখ, ইমেল।
কে বলছো?
জিজিদা বলছি, জিজিদা একটা ইমেল পাঠিয়েছি।
জিজিদা বলছো?
হ্যাঁ, একটা ইমেল পাঠিয়েছি দেখ, ইমেল।
ফোন করিস না আমারে
ইমেল পাঠিয়েছো? আচ্ছা ইমেলটা আমি চেক করছি, দাঁড়াও
হ্যাঁ, ও তোর প্রেজেন্টেশনটা একটু ছবিগুলো বড় বড় করে দিয়েছি।
আচ্ছা ছবিগুলো তোমার কাছে যেটা আছে তোমার থেকে প্রেজেন্ট করো না, কোনো অসুবিধা নেই।
না, তোর থেকে কর না, আমি পাঠিয়ে দিয়েছি,
হ্যাঁ।
ডাউনলোড করে নে।
আমি দিয়ে দিয়েছি।
ডাউনলোড করেছি, আমি এখন বললাম না আজকে একটু ঘেটে আছি, অন্য জায়গায় আছি। নেটটাও ভীষণ
তাহলে ঠিক আছে, আমার ল্যাপটপ থেকে
চেষ্টা করছি, দাঁড়াও।
হ্যাঁ, যদি হলো হলো, হাতে সময় আছে, 8 ঘন্টা সময় আছে এখন।
ইউটিউবে একটা লিংক আছে দেখ
কতবার সামনে থাকবে? আরে এটা তো লাগছে না।
তখন তো দেখতে পাচ্ছ।
এবার
না,
তুই আবার
না,
ক্লিক কর
দাঁড়াও।
ইউটিউবে আয়
আমি-
ইউটিউবে
আমি দিয়ে দিয়েছি, তোমায় শেয়ার করতে হবে না।
ওদের ইউটিউব
আমি
ওইখানে দেখবি ইউটিউবের একটা লিংক আছে ওই পেজে। হ্যাঁ হ্যাঁ ওই পেজে ইউটিউবের লিংক আছে। হ্যাঁ
অনন্ত স্যার, গুড ইভিনিং। অভিজিৎ,
Yeah,
please start.
let's start now.
Yeah.
That is 59.
Hmm.
Should we start, sir? Sound is coming. Anyway, good evening, everyone. On behalf of OCAD, I welcome you all. Very well, welcome to all our faculty members and everyone who is attending this program. I would like to hand over the session to Mr. Kapil Roy for the progress.
Thank you, Mr. Abhijit. Thank you, Mr. Abhijit.
বেশিরভাগ লোককে মিউট করে রাখতে হবে,
হ্যাঁ হ্যাঁ স্যার।
তাহলে প্রচুর রিভারবেরেশনস আসছে। যে যখন বলবেন তারটা আনমিউট রাখবেন, আদারওয়াইজ বাকিগুলো মিউট করে রাখবেন।
Should I start?
Yes, please.
Good evening. Just to start with, to say we are thrilled and excited.
Tapanda, the echo is coming from your side. The
Why?
echo is coming from your side.
Now, I believe Tapanda has started his this thing also. YouTube also. That is the reason.
No.
Okay, now okay.
Now this is okay.
Yeah.
হ্যাঁ, ওকে,
Now do that.
ফোনটা দূরে রাখলেই হবে।
Good evening. To say we are thrilled and excited to see the galaxy of stars is an understatement. Where I have been entrusted with the job to set the tone, today's webinar, episode number 1, food injuries, with focus on current concept in food injuries, which is initiated by Malda Ortho Club in association with West Bengal Orthopedic Association and Beyond Boundaries, an academic initiation from OCAD where life wins. Someone rightly said, learning is a continuous process, and keeping the same in my mind, may I have the pleasure of introducing today's current president, Dr. Chinmoy De, and change the slide, please. And Dr. Parthasarathi Sarkar, Honorary Secretary, West Bengal Orthopedic Association. Dr. Pitush Chatterjee, former President, West Bengal Orthopedic Association. Dr. Devajyoti Das, former President, West Bengal Orthopedic Association, and current President of Malda Orthopedic Club. And today's moderator is none other than Dr. Gigi Kaur. And let me have the pleasure of introducing today's faculty, Dr. Kartik Hariharan, Consultant Orthopedic Foot and Ankle Surgeon, Royal Joint Hospital, United Kingdom, followed by Dr. Swarnendu Samanto from Peerless Hospital, Dr. Abhijit Banerjee from Howrah, and Kushal Nag and Dr. Asim Chaudhary. Next slide. Just to highlight few bullet points regarding Dr. Gigi Kaur. He was the former lecturer and assistant professor of IPGMER, Kolkata, and he held different significant posts during the past. To name few, he was the chairman, Computer Subcommittee, Orthopedic Association. He was also the honorary joint secretary, West Bengal Orthoplasty Society, and founder and honorary vice president, Spinal Cord Society, West Bengal. Currently, he is the professor of orthopedic Apollo Clinical Hospital, Kolkata, and consultant orthopedic surgeon and arthroscopist, founder, member, and honorary secretary, Kolkata Arthroscopy Sports Society, and founder, member, and honorary secretary, Association of Orthopedic Trauma Surgeon. And he acted as faculty speaker, panelist, chairperson in number of 100 of workshops and symposium on trauma, arthroplasty, and arthroscopy across the country. Just before concluding, next slide. There is a platform called OakMed from OakHeart, a platform where you can share medical queries via email at oakmedoakheart.com, and the reply will be given within 72 hours from OakHeart Medical. With this, I hand over today's proceedings to Dr. Gigi Kaur.
Dr. Kaur, welcome.
Hello.
And it is up to you.
Yeah. Hello and very warm good evening here. We can have the pleasure of the presence of our UK faculty and the local faculty also. The concept of this ankle and foot symposium was brainchild of Dr. Devajyoti Bose, who is the president of Malda Orthopedic Club and former president of West Bengal Orthopedic Association as well. We planned for a 2 days extensive symposium in April, but that couldn't be because of Corona. But we didn't back out entirely. Instead, we had a plan of having this webinar here in 2 or 3 parts. The first part is today on foot injuries. The positive side of this Corona episode is that we can have international faculty among us, which we could not dream of if it was a physical meeting for logistical and other considerations. But we are free rather from these shackles and boundaries of physical meetings now. That's why there's a screeching sound has stopped, I think. Yeah. So am I audible now again?
Yes, sir. Yes, sir.
Thank you. So let me have the pleasure of having our president, Malda Orthopedic Club President, Dr. Devajyoti Bose, to say a few words before we start with our academic proceedings. Dr. Bose, please. Technical moderator, please hand over this.
Yeah.
unmute Dr. Bose.
It is, sir, please speak. Sir, please speak.
Dr. Bose, please.
Dr. Bose is to unmute, please.
Yeah,
Sir, please unmute your side, from your side. Sir, please unmute from your side. Yeah. Sir, please, yeah, it's okay now.
I am audible?
Yes, audible, sir.
Yeah.
Sir, you are audible. You can speak. Dr. Bose, you are unmuted and you are audible. You can speak.
Yeah, hello. Hello, I am audible?
Yes, sir, you are audible, sir.
Audible.
Yeah. It is a proud privilege for me. Please, it is a proud privilege for me. I don't know. Hello.
Sir, you are audible.
Hello.
Sir, you are audible.
Am I audible?
Sir, you are audible, sir. You are audible.
Maybe his earphone was not working.
Yeah. Sir, you are audible.
Hello. I am hearing.
Yes, sir.
I am
Yes,
hearing
sir.
Dr. Gigi Kaur's sound.
Yeah, you can hear. We can also hear you.
Yes.
No problem.
Yeah. Okay. Yes. Okay. I am telling. Okay. It is my private privilege from the Malda Orthopedic Club to invite all of you. Yeah. Yes, I'm speaking. Can you? I am audible. I am audible. Yeah. Yes. Yes, I am unmuted. I am unmuted.
Sir, you are
I am
audible.
unmuted.
Sir, you are audible.
Yeah, I am audible.
Yes.
Yeah. It is my proud privilege. Yes. It is my proud privilege to welcome you all, especially our president, Dr. Chinmay Dey, our secretary, Dr. Yes, I am telling. Yes. It is my proud privilege from Malda Orthopedic Club to welcome you all in this webinar. It was supposed to be. I am speaking. I am audible.
Yes, you're audible.
Yes.
Just speak.
Yes, sir. Sir, you are audible, sir.
Yeah. So I am
আপনাকে
speaking.
হ্যাঁ স্যার শোনা যাচ্ছে, আপনি বলুন স্যার, আপনাকে শোনা যাচ্ছে।
বলছি আপনার চাও, it's a proud privilege for me to. Hello. Yes, it's a proud privilege for me. It's a proud privilege for me to welcome you all in this. Okay. Okay, Gigi, you tell on my behalf. Gigi.
Hello, শুনছি বল।
Yes. Gigi, you speak on my behalf. You speak on my behalf.
হ্যাঁ দিচ্ছি, ফোনটা ওকে বাপ্পা থেকে ফোন করার চেষ্টা করছি। তোমার এখানে ফোনটা ঢুকে গেল।
Dr. Kaur,
Yeah.
I think Dr. Bose having some network issue.
Network problem because
আমি শুনতে পাচ্ছি না।
Malda is about 350 kilometers away from Kolkata, and recently because of this cyclone issue, we may have some network problems. We had network problems in Kolkata even. So directly I'm taking over and handing over the mic to Dr. Karthik so that we can hear something about the initial assessment of an injured foot, the clinical assessment and the radiological assessment. The idea is to make aware the general orthopedic surgeons who they are not foot and ankle surgeons, but they have to tackle with foot trauma day in and day out, especially because this is a very common trauma. So with that idea, I hand over this to Dr. Karthik Hariharan from UK. Dr. Hariharan, please share your screen now.
Yeah.
Thank you.
Thank you very much for the invite.
Yes, sir.
It feels quite strange to be called an international faculty, even after having been abroad for nearly 37 years, because you can take a man out of India, but you can never take India out of the man. Are you all able to hear me, most importantly?
Yes, sir, nice and loud.
Okay, lovely. I'm going to talk about the assessment and imaging of the injured foot and ankle. There are a lot of areas which are extremely well covered and everybody is fully aware of it. And I will do my best not to be over repetitive. We know that the foot is a complex organ. It's an end organ, it's a sensory organ, it's an ambulatory organ. And so it's got very specialized areas, including bone, joint, soft tissues, receptors, tendons. And it is for that reason, if the foot is injured, we need a degree of higher order thinking, or we can't be thinking in terms of a unilateral long bone fracture, which is a much more straightforward sequence. So we need to be able to create a portfolio of information which we can critically evaluate, analyze, and then try and apply into setting up a treatment protocol. In order to do that, we need to be able to understand what we are looking for and try and remember how to link what we have gained by way of clinical examination into the treatment protocol. So it is essential that we know the anatomy. It is extremely important for us to understand the mechanism of injury, as it tells us a huge amount about the potential for injuring various parts of the foot. We then take time to assess the signs and symptoms of the injury and analyze it carefully in order to arrive at a presumptive diagnosis, after which we can use imaging to gather more information to embellish this diagnosis, to confirm it, and also to help us in planning treatment. If we looked at mechanisms of injury, it is really, really important that you speak to the ambulance men, passers-by, or the patient themselves if they can communicate it to you about the various mechanisms of injury. And these are usually the common mechanisms of injury where we have injuries to the foot and the ankle, the classic falling from a height, from a ladder, where you've got the compression fractures or the burst fractures of the bones, usually of the hindfoot. You have torsional injuries or twisting injuries where you have sprains, fractures, fractures of the midfoot and the ankle. You also have direct trauma where something is dropped on the foot, resulting in crush injuries, particularly of the soft tissue, but also of the tarsal and metatarsal bones. And then, of course, you've got the chronic scenario of stress fractures, chronic sprains, non-unions, etc. So if we looked at clinical assessment, the tenets of clinical assessment is really to ask the patient. A habit of listening is very cumbersome to us sometimes. We've got a big clinic, lots of patients, but it is extremely important to allow the patient to talk, to show us the site of the pain, because the patient's perception of where the pain is often the most accurate site of the pain. And once you have actually located the site of pain, it is then starts to get easier to identify the anatomy in that part of the foot. And then you can assess the signs and symptoms of the injury that you think this particular part of the foot or the ankle has suffered. And then, of course, it's the standard format of see, feel, move, and talk. However, in the traumatic situation, move and walk is often very painful, and the patient says, look, I can't move this ankle, it's too painful for me, or I can't walk because the foot is really hurting me. So often it is a question of inferring as to what the potential area of injury might be. As a general rule, antalgia, or the inability to weight bear on an injured lower limb, is usually a sign of bony injury. So if you want to undertake the classical method of examination, you've got the tenets of assessing the contour of the foot, and this is usually obscured in acute injury by huge amounts of swelling, so it may not be entirely possible, but once the swelling settles down, it is possible to work out if there is an abnormal bony contour, as you can see in this midfoot, where there is a large medial bony abnormality, which would suggest to us that this is a midfoot injury. You then look for tenderness at various parts of the foot and the ankle. It's extremely important to assess what the soft tissue integuments of the injury are, because that will tell you a huge amount about the amount of energy transfer that has occurred in this injury. And of course, measurement of pulses, dorsalis pedis and posterior tibial pulse usually, but also let's not forget, we may have to assess more proximal pulses in addition, looking at it as a limb problem rather than as a foot and ankle problem, and also to assess whether the neurological function is adequate. If you want to understand soft tissues, some peculiarities of foot and ankle injuries are that there is very little between skin and bone in many of these areas, and pressure between the skin layers and the bone is often very high, and this can lead to blisters, and in particular in high velocity injuries such as the hindfoot injuries or the midfoot injuries, this can be quite spectacular. The sign of plantar ecchymosis is usually a sign of severe injury, and this is almost pathognomonic of injuries that particularly affect the midfoot and is classically seen in a severe Lisfranc fracture dislocation. If you looked at fracture blisters are very common in foot and ankle surgery, particularly injuries of the hindfoot. Beware of the hemorrhagic blister. It's an extremely dangerous sign, because it usually means that there is dermal epidermal dissociation. So it's a shear injury where all of the radial blood vessels that come up from the dermis into the epidermis are lost because there is uniaxial skin tension. And often this will slough off as almost a full thickness skin loss. And it is very important that we don't plan any surgical intervention during this period, because we don't know how much of the skin is going to survive and how much of it is going to die. So you wait for what is called as the wrinkle sign, where the swelling goes down, the blisters settle down. You try and avoid opening hemorrhagic blisters, because again, as I said, it's an area which will colonize very quickly. If it is a non-hemorrhagic blister, you can aspirate it and allow it to settle down. So this is a very important component of clinical examination itself. When you first see a patient with huge hemorrhagic blisters, you know you're going to be in for a rough ride with this case. What about ankle injuries? If we looked at ankle injuries, I'm not going to go into the fracture scenario, because if the fractures are displaced, the limb is displaced, the axis of the limb is displaced, and the problem is very obvious. But let's not forget that the ankle consists of three columns: the lateral column with the lateral malleolus and the lateral ligament, the medial column with the medial malleolus and the deltoid ligament, the posterior column, which is the part of the syndesmotic complex of the posterior malleolus, the posterior inferior tibiofibular ligament, and the syndesmotic ligament. You also have to assess ligament, tendon, and cartilage pathology. Ligament pathology is difficult to assess in the acute setting, but it may be possible in the subacute setting, where you can localize the pain to one or other of the collateral ligaments. Tendon injuries, particularly injuries of the Achilles tendon, are often missed, and it's remarkable how often patients come saying, I had an injury to my ankle, the back of my ankle is very painful. The accident and emergency doctor gets an x-ray and says, it's all fine, I can't see any fractures, away you go, failing to recognize that there is an Achilles tendon rupture. So this is really important for us to understand, that we need to make sure that there are no tendinous disruptions. Cartilage injuries are perhaps the most difficult to assess. And again, we have to infer from the degree of comminution of a fracture, which is intra-articular, or we can assess from the degree of energy transfer that there is likely to be significant cartilage injury, and we need to watch out for that. Again, in the acute setting, stability testing is going to be really difficult for us. I think we need to be able to wait until the swelling goes down before we can assess stability. What about things like syndesmotic injuries? These are, again, injuries which are often missed. The clinical findings are quite subtle in purely ligamentous syndesmotic injuries without associated fracture. There is often the difficulty in differentiating whether this is a supination external rotation stage 2, where there is no syndesmotic involvement, or a stage 4 where there is complete syndesmotic disruption. You also need to make sure that you examine the limb as a whole, as I said before, because you could miss a mesonerve injury where you may have a proximal fibular fracture around about the knee. And so you need to be able to examine that. And if there is any pain in that region, you must x-ray the whole of the limb, particularly if there is a talar shift. We know that injuries to the posterior malleolus, particularly, is associated with a syndesmotic disruption, because the posterior inferior tibiofibular ligament is actually attached to the posterior malleolus. And so we need to be very careful in assessing that. We also can easily assess deltoid integrity clinically, but it's often difficult to differentiate it from, say, a tibialis posterior pathology or injury, or possibly a medial subtalar injury. But it is possible for us to assume that there is a deltoid injury simply by palpating it. What about physical examination for syndesmotic injuries? These are some special tests that you can do. And again, it is extremely important that for every ankle injury, we actually work out if the syndesmosis is intact, because if we know that the deltoid is intact and the syndesmosis is intact, 99% of these injuries are stable injuries, and we could theoretically treat them in a conservative manner. So the external rotation test is quite a sensitive test, which involves stabilizing the lower part of the leg by compressing the fibula up against the tibia, and then externally rotating the foot to see whether we can stress the syndesmosis and cause pain. There are other tests that we can do. One is called the Amendola test, after Ned Amendola, who described it, where you use a 2-inch cloth tape about 2 centimeters above the malleoli, and then when you ask the patient to stand, the tape holds the syndesmosis together, and so there's pain relief with weight bearing. You could also do another simple test this is an impingement test, by asking the patient to sit cross-legged and dropping the foot into eversion when the syndesmosis would start to hurt as the fibula rotates outwards and backwards. What about midfoot injuries? These are often more difficult to appreciate, because there are very, very large numbers of ligaments, bones, joints, etc. And so localizing it to a particular area is often quite difficult. The mechanisms that are involved in midfoot injuries usually are torsional, axial, or a combination of multiple forces, and is therefore often poorly localized. The patient can only tell you that the middle part of his foot is very painful. But it is extremely important that we examine both columns, the medial part of the midfoot, which consists of the navicular, the medial cuneiform, the first and second metatarsals, the middle column, which consists of the intermediate cuneiform, part of the navicular that forms the joint with the intermediate cuneiform, the third metatarsals, and the lateral column, which is the fourth and fifth metatarsals with the adjoining cuboid articulation. So we must remember that if you have an injury to the one column, it is almost impossible not to have an injury to the corresponding column. So if the medial column is injured, so if you've got a talonavicular dislocation or a navicular cuneiform fracture, you almost always have to look in terms of whether there's something happening in the lateral column. The middle column is not that important, but it may dislocate when both lateral and medial columns are involved in the equation. So you must have an index of suspicion that there are multiple segments of the midfoot that are involved in the injury. And therefore, very often, imaging is quite essential. Many of these we can subsequently, once we've done an initial assessment, we can test by means of fluoroscopy as to whether there are instability patterns that are forming here. So you can see in this midfoot series of photographs that when you look at it from the plantar side, you can often appreciate a subtle abduction deformity hinging at the midfoot with the medial prominence. You can see the classic plantar ecchymosis as a result of severe Lisfranc injury. And on the picture on the right, you can see that the foot is squared off and swollen, having lost its normal contour compared to the left foot. So this kind of encompasses a rough idea as to how your thought processes must run when you look at a foot and ankle injury, isolate the site of the injury, pay specific attention to that particular part of the anatomy of the foot and the ankle, hone your skills in trying to get as much information from the patient by way of mechanisms of injury so that you can make an accurate diagnosis, which you can then subsequently confirm with imaging. And therefore, imaging is largely for confirmation of the diagnosis rather than diagnosing it itself, although sometimes you do require imaging to actually make a diagnosis. Very often it serves to solve diagnostic confusion. So if you've got classically the midfoot, if you've got multiple fractures and you're not able to make out clinically or by plain x-rays as to what the extent of the injury is, you can then work from the point of view of getting a CT scan or an MRI scan, whatever is indicated at that point, in order for us to be able to plan treatment and assess recovery processes. So the various modalities that we use are plain radiography, CT scans, MRI scans, isotope bone scans occasionally, and ultrasound scans, particularly for soft tissue problems. What about plain radiographs? Now, I would suggest that even if the patient has got fractures, particularly ankle fractures, if there is only a unimalleolar fracture or a combination of medial and posterior or lateral and posterior fractures, if it is possible, even if it's a simulated weight-bearing X-ray, that often gives you a lot more information than a non-weight-bearing X-ray with the foot flopping into equinus. That doesn't give you a great amount. As a general rule, you need multiplanar X-rays, 2 planes in the ankle and 3 planes everywhere else in the foot. And sometimes, even in the ankle, if you're suspecting a subtalar injury, you may require a 3-planar set of a series of X-rays. The idea is from the X-rays is to assess the anatomy, to check to see if the joints are congruous. You can occasionally pick up osteochondral injuries or infer that the chondral damage can be substantial in an injury of this nature. You can also undertake certain forms of stress tests to actually find out if there is significant dislocating injuries to the various joints. In the ankle, it is mandatory that we have a mortise view, which will give us a clear perception of what the lateral gutter is. And this is very important to assess the congruity of the joint in this particular area. As I said before, try and get it weight-bearing or simulated weight-bearing if possible. We can undertake stress tests for deltoid ligament integrity and syndesmotic stability. But the X-rays are often used to assess the alignment once you've diagnosed fractures in it, to see if there are multiple fractures, unicortical or bicortical fractures. And of course, in the pathological setting, let's say you had a fibrous cortical defect and the fracture went through, it is very useful to pick these up. You don't need fancy CT scans. It's actually quite easy to pick it up with plain X-rays. Stress fractures in the delayed setting, you can see periosseal reactions, etc. This is the classic example where you've got a non-weight-bearing right ankle X-ray on the right, and when you weight bear, you immediately find that the fracture that you really can't see on the X-ray on the left becomes obvious, and then there is a talar shift suggesting that there is a deltoid ligament injury in addition. It's a very simple addition of weight bearing that brings this to the fore. Although the patient may have some discomfort and pain, it's well worth trying to push for a weight bearing X-ray. And there are several methods of getting stress X-rays for us to work out. I'm sorry, I think I've lost the pictures there for some reason. There is the gravity stress view where you ask the patient to flop the ankle onto an everted position by lying on the bad side and then get an anterior posterior X-ray, and this will show you a gap. This X-ray is pretty obvious. You don't need to stress this X-ray at all. What these kind of pictures will show you will also give you a clue as to what the mechanisms of injury are. This is a classic example where you've got a picture on the left which shows you that this must have been an axial compression plantar flexion injury because it's dislocated backwards. The picture on the right will show you that this is an eversion external rotation injury. So it also gives you a lot of information about what the mechanisms of injury are. What about the Lisfranc? And I'm not going to go through this. Everybody must have seen this on the internet in great detail. This is basically the AP is used to assess the first and second tarsometatarsal joints, and a 30-degree oblique is used to assess the lateral tarsometatarsal joints. A true lateral is extremely important. Many of us will just only take two views, but a true lateral, this is the same patient, you know, the three x-rays are of the same patient, and you can see by looking at a true lateral view that there's plantar dislocation of the tarsometatarsal joint complex, which we would have missed if we had looked at just the AP and the oblique x-rays. And that's why very many of these injuries are often missed and undetected. And the lateral view, again, it needs to be congruous, and it's often useful to get this in a weight-bearing fashion if there are not too many fractures and the patient is not in too much pain. Let's not forget the ubiquitous flex sign, where you've got this little piece of bone which, although being little, tells a very big story, because it is that little piece of bone to which is attached the entire Lisfranc ligament. And this is often, again, missed, because what the mind does not know, the eye does not see. But you can see there is a gap between the first and second metatarsals, and you can drive a truck through that, but there is also a piece of bone that's sitting there, which is the avulsed Lisfranc ligament from the plantar aspect of the medial cuneiform. What about the CT scan? You know, the CT scan is largely used to assess the alignment, to assess the pattern of fracture, in order for us to be able to get a three-dimensional view of what the fracture is going to look like, and then to assess our planning processes. It is easy access. It's probably easier to access a CT scan than an MRI scan, where I come from, because the CT scanning is very quick, but it is high radiation. And you know, sometimes you've got to be somewhat careful, particularly in young children, girls, etc. If you remember, most hindfoot major energy transfer injuries are soft tissue injuries complicated by a fracture. And so we have this philosophy of using an external fixator to span out the fracture complex so that the soft tissues are not contracted. You then do your CT scans in order to be able to plan for treatment. It is particularly useful in intra-articular fractures because you're able to plan your fracture treatment. You use the lowest, for example, in this pilon fracture, you look at the lowest slice closest to the articular surface, and then you can plan your surgical approach, you can plan your fixation, etc., in an effort to get optimal articular reconstruction. This gives you a much better idea than an X-ray would of the number of fragments. Again, the complicating factors like this huge die punch fracture, reverse die punch fracture, which has punched its way into the talus, and it gives you a huge amount of information as to what you're going to encounter once you open it. Again, likewise, there is a method in the madness. Initially, when you look at this X-ray, you have no idea what is broken, what is not broken, which joints are dislocated, and a CT scan will give you comprehensive information about the nature of the injury. MRI scan seeks to assess soft tissue and cartilage. It's not really useful for acute fractures because there is a whiteout. It's huge amounts of bleeding, and so you often find that the MRI scan is less useful. However, it is quite useful in the stress fracture settings, in delayed unions or non-union settings where you will continue to see edema in a fractured area. So these are examples how you can use an MRI scan. The pictures on the top show you an osteochondral fracture. I beg your pardon, where you can see huge amounts of edema on the medial side associated with fragmentation of cartilaginous material. In the bottom right, you can see a non-union of an os calcis fracture, which is beautifully demonstrated. It also will show you things like peroneal impingement in the case of hindfoot fracture and other ligamentous pathology. It is particularly useful in the delayed syndesmotic problem, where you often struggle to pick this out, even using a CT scan. An MRI scan here shows you a beautiful definition of an injury to both the AI-TFL and the PI-TFL, as well as the syndesmotic ligament, because there's fluid going from the front of the ankle, front of the syndesmosis, right to the back of the syndesmosis, and there's complete disruption of the PI-TFL, which is the major stabilizer of the syndesmotic complex. There are other components to it, which I'm not going to go into great detail. The ultrasound scan is quite nuanced because it is operator dependent. You need a good sonographer in order to be able to get the right information. And it is used for specific purposes, classically used for tendon ruptures, ligament ruptures, although some people have used it for assessing stability. So you could do an anterior drawer test and assess how far the ankle subluxes forward, but these are all not in the acute setting. It is usually in the more subacute or chronic settings. Isotope bone scans, again, this is more in the subacute setting, particularly in situations like stress fractures or chronic syndesmotic injuries. You can pick out pathology. The white cell label scan is only and almost only when you have got a suspicion of infection or possibility of osteomyelitis. We use diagnostic injections even in the acute setting, and it's invaluable for selected cases where you're thinking in terms of a peroneal pathology or a lateral ligament injury. You can inject diagnostically to see if you can take the pain away for a short while. The last part of my talk, if I've got time, it'll take only a few minutes. This is a very important part of foot and ankle injuries. Is the injured foot actually salvageable? And I think I'm laying more attention to this because the rest of what I've told you, you can pick it up in any book or in any website. But the decision as to whether you can salvage a severely injured foot and ankle injury or not is actually difficult as a science. It's more with experience, and it's almost imbibing information from a variety of sources. There are fundamental questions when you see severe foot and ankle trauma, an injury, and say, is this foot actually salvageable? Do I need to use my resources, my effort in salvaging a foot that eventually becomes completely useless? And that's a very important question for a number of factors. It's important because we know that early amputation actually is far better results-wise than doing a secondary amputation after months or even years of suffering with a foot that's painful and useless. And in doing so, you cause severe psychological, financial, and other implications in the patient, which is not really good for us. If you salvage the wrong limb and you doom the patient to a flail limb or a limb which is very painful, it costs huge amounts of money in order to be able to rehabilitate this patient. And eventually, after all of those attempts, you eventually land up amputating the patient with a very poor psychological outcome from these injuries. If you want to look at salvageable limbs, there are varieties of things that you use. You use the mangled extremity severity scores. If there's a score of more than 7, it's 100% indication for limb loss. But many of these are almost on the table, not an initial clinical assessment. And I think the LEAP study clearly defines that for us, that severe open hindfoot and midfoot injuries with degloving or nerve injury results in a poor outcome for many of these patients. So there is a lot of previously held dogma. So if you lose plantar sensation, you chop the leg off, or if there is a very long time to debridement, you have to amputate, etc. However, this is a very simple thing that originated from India, which I don't know how many institutions in India actually use, but I've used that concept by Professor Rajashekharan of the Ganga Hospital School, and it really does make a huge difference with particular reference to severe fractures of the tibia. And it's something that you can extrapolate to other parts of the body too. And I would urge you all to go and read the paper in the Journal of Bone and Joint Surgery from 2006. It's a seminal piece of work, and I think we as orthopedic surgeons really should be looking at this in greater detail, because it does, for the first time, allow you to make decisions which would affect the long-term outcome for the patient. There are huge technological advances that have also occurred with external fixation, stage treatment. We know that staging treatment, the span, scan, and plan philosophy has made significant advances. And if you looked at this picture, a few years ago, you'd have just simply completed the amputation, but this patient actually had an intact nerve, had vascular repair, and walked out of hospital. So please don't rush for the knife. If you have got criteria on which you can decide whether to amputate or not, it makes it easier for us to say, yes, I'm going to throw in a lot of effort in trying to salvage this limb because I know this patient will have a good outcome. Again, another patient was a severe degloving. This required only serial debridement and compression therapy, and we managed to heal and resolve this limb. And again, this just goes to show you, you make your initial decision on clinical examination, history taking, comorbidities, and a holistic approach to the patient, which will give you the armamentarium in order to be able to salvage limbs. Lastly, this is the classic burst foot situation. And if you see this in the accident and emergency department, you know you're in for a difficult time because this is a very, very high velocity injury. This was a motorbike racer who came off the track with this injury. You can see that there's a vascular injury to the distal tibia along with severe open fractures. And you can see that that's the cuboid looking at you from the sole of the foot. And the x-rays paint a dreadful picture. And we could have said, look, we're going to amputate this because I think he's got everything. He's got vascular injury, he's got severe fractures, open injury, etc. But what we didn't do that. We staged this, we framed it, we grafted it, and 10 days later we started to notice that the fourth and the fifth toes were necrosing. So we took that off. But 6 months later, the patient actually did remarkably well and unfortunately went back onto a motorbike. So in order to just conclude this section, really, really important for us to understand the history of the injury and the mechanism of the injury. Let us not forget, for every foot injury that you have from a fall in a height, you will have a few patients who will have a lumbar spinal injury or injury in the pelvis, and you need to have a holistic approach to examining these patients. Don't forget the comorbidities. Plan your investigation so that it gives you the maximum information. Use the right investigation for the right information, which will help you in successfully planning for eventual treatment of this patient. Thank you very much.
Thank you, Dr. Hariharan, for an excellent overview of the difficult situation, difficult scenario, because so many, as you have already said, that so many structures, so many named ligaments, so many bones and vascular muscle components of the foot, including the sensory component, is there. So you have to assess quickly because maybe sometimes timing is running out for the clinician in an acutely injured foot, particularly the patient, if there is a multiple injuries. Yes. Maybe sometimes it happens that the foot gets the list of preferences along the line of management, and maybe the patient will ultimately have all the other bones, all the major bones united, and the injuries to the foot stays with him or her for the rest of her life because the nagging problem coming out of there. And your lecture has basically, to me at least, helped to dissipate the cobwebs of confusion. And having some, from quoting you himself, that making some method out of madness. That is most important, because when we examine a foot in a disease condition, also in a clinical condition which is non-traumatic, maybe traumatic, we get slightly odd about so many structures and the biomechanical functions of those. So correct. As your lecture progressed, especially the good things come at the end. That's the importance of having the combination of experience, evidence, as well as your environment, what this particular patient wants to be, what this particular patient's activity level is and the demand is, and of course the purchasing power, the finance. Everything has to be taken into consideration, and ego has to be left out of this equation.
Absolutely right.
Because I have a good plastic surgery department. I try to salvage this limb and wait for 6 months, and after that the patient gets bored and economically drained out, and ultimately maybe amputation is done. So that's a fantastic point from your side, and I will take the questions later on. I must not forget thanks to Abhijit Banerjee because on our behalf, he contacted you, he invited you and got your consent. So
It's my pleasure, sir. It's always
no.
my pleasure.
It is always. Can I say something, Sujit?
Yes,
Yeah.
please. Because the mic, I'll hand over the mic next to you because of your presentation is coming up.
Because it is always Kartik sir is so much so much fabulous, and I always request everyone that there is a BBC4 production that is the Incredible Human Food. That was the I saw that in 2017 first.
Okay.
Though it was in 2015, I think, sir.
Yes.
Okay.
Yes.
So I request everyone just go through that, dissected the Incredible Human Food, and human food, and that is the really incredible that is made by Kartik sir.
Okay. So let us now switch over to Abhijit himself. Suppose we have taken a decision to operate in a injured foot. I'm not saying that every injured foot has to be operated, but when the decision has been taken for operation, especially for the inexperienced surgeons, there can be so many problems, starting from planning stage into the preparation stage and the procedure itself, and the problems may not go away with the surgery itself in the rehabilitation phase and maybe the monitoring phase. So our aim of this next lecture from Abhijit is to minimize those complications, because we know that in this litigious society, we can have a significant amount of medical litigations, compensatory or otherwise, arising from ankle and foot region. It's a significant percentage of cases. So Abhijit will enlighten us about how to keep ourselves out of those pitfalls. Over to Abhijit. Please share your screen.
Thank you, sir. Yeah, I just want
everybody
to
else, please mute themselves.
Sichandu, hello. Hello, Mr. Sichandu.
Yes,
yeah,
sir.
Yeah, can you share? I cannot share my screen. Just help me.
Sir, first আপনার প্রেজেন্টেশনটা খুলুন।
But there is a hanging, something is going wrong.
Or if you can mail me immediately, I can share it from here.
No, it is just open.
Just open your presentation.
Yeah.
Minimize it and then go to share. There is a share button, green color button.
Just do it. It is hanging now.
Abhijit did have some problem in another previous webinar also, but that was with the video. I think this time it will play out right.
I think there is any network issue, Gaur sir, with Dr. Abhijit sir.
Network issue is him?
Because he's just fixed right now.
Oh. So
I think he will join once again. He has left.
Maybe. Let us give him about say 3-4 minutes.
Yeah, it will. So in the meantime, that time Dr. Bose was not audible. So now Dr. Bose is audible, I think. I unmute Dr. Bose.
Yeah.
Dr. Bose will say something.
Okay. Over to Dr. Debojyoti Bose.
Dr. Bose.
Yes.
Sir, now you're audible. So we want to hear your words from your.
Okay. First of all, I'm very sorry that my computer was giving me some trouble. Anyhow.
Okay.
So
Anyhow,
I welcome again all in this webinar. I just heard Dr. Kartik Hariharan's lecture. It was excellent. and
mind
astonished to
blowing,
see the cases which he has shown us and salvaged
and I
the
was
food.
astonished to see the
It was
salvage
beyond
the
our
food.
expectation.
It was beyond our expectation. Such a beautiful clinical photographs will present to us. And that's all. And thank you very much, Abhijit, to bring you here in this webinar. And so we hope that from now on, ready for his slide. Is it, Abhijit?
Dr. Abhijit is not there. Dr. Abhijit is coming back because he having some network issue. Sir, he has given a message in the chat box.
Please inquire whether Dr. Swarnendu is there. Dr. Shamanta is there or not?
Yes, I am there.
Dr. Swarnendu is there.
Swarnendu? Yes, follow.
Can we have your presentation on screen?
Yes, I can go ahead.
Yes,
Whenever.
yes,
I am always ready. I am waiting for last.
Always the saver.
I am always there. Whenever my turn comes, I am just waiting. No problem.
So we'll hear some two cases, no, Swarnendu?
Yes,
one after another.
Yes.
Fine.
সুবিধা তোমাকে আরেকবার ধন্যবাদ দিই তুমি এত কষ্ট করে যতবার বসবো অতবার তুমি বানিয়ে দিন
Just give me just 2 seconds. Probably. Can you see my slide?
Yes,
sir.
Yeah, because this is a great honor that this has been organized by the West Bengal Orthopedic Association, and already there's so much of galaxy of stars over there, like the 2 past presidents and over there. Okay. Is it a great honor?
There are 3 past presidents.
Yes, I am referring to Protuzda and Debojyoti Bose only.
Okay.
And they are the 2 past presidents, no?
Yes, yeah.
And Chinmoyda is the present president. So that's why I'm presenting that in front of 2 past president and 1 present president. And I will be just the thing is that Professor Kaur has somehow manipulated my slides, but I have not changed. I could not receive the slide. Even I checked in the spam folder, but it was not there. But probably you can see my slide. Okay. So this was an injury around the ankle, and it was just a blast of the tire of a bus. Okay. So young guy, can you see the slide, Gourda? Hello.
Slide is visible.
Okay. Can I go ahead?
Yeah.
Oh, so yeah, young guy, and if you see the X-ray, you see that X-ray. Probably, if you don't see the X-ray very carefully, then probably you might miss that something has happened because the guy was received with a slab like this way. And if you see the X-ray, there is nothing wrong on the lateral film, but there is a very, very thin film, thin crack sort of thing over there. Okay. So whenever you find something is wrong around the talus, probably we always tell that whenever it is there, you must have a CT scan. Okay. So CT scan was done. Now this is the CT scan. Can you see the CT scan, Professor Kaur?
You can see.
Yeah. Can you see that CT scan?
Yes, you can see.
Okay. So because my net is bit poor, that's why I'm repeatedly asking. If you see the CT scan, now you see that there is some problem around there, and this is the way the fracture is there. Okay. And you can find the fracture line over there. Okay. So plan. So what is the plan? I will ask our faculty from UK, panelists like from UK, my dear friend Hariharan. Dear, are you happy with the?
Yes, absolutely, sir. I just wondered whether you had any sagittal cuts. Presumably, if you had it, you would have put it here. But sagittal would be quite useful.
Yeah. The sagittal cut was there, but this is for just for the present. It is there, and suppose this fracture is there, and you can see the fracture over there. Okay.
Yes, of course. Yes,
so
sir.
How you are going to? You are going to definitely operate. How you are going to plan?
The first thing, just to highlight what you initially said about the mechanism of injury, that this is exactly what I was saying in my talk. So you said it was just a blast from a lorry tire.
Yeah, bus tire. Bus tire was just blasted. Just he was sitting on the bus tire seat.
Yes. Oh, wow. So that is almost, I don't know whether you had a chance. There was a very, very good paper written about blast injuries to the hindfoot, written by a UK surgeon who spent time in Afghanistan during the war, and the soft tissue components of a blast injury. So it was basically, they would have an incendiary device which would blow up underneath the armored truck, and the steel, reinforced steel plate would come and smash the heel, and he presented a series of calcaneal fractures. And in these, there was a 40% amputation rate. 40% of these. So what you've described is actually quite a high velocity injury, sir. And that's why you've got this awful injury. This is a difficult injury. And I agree with you. I think with the degree of incongruence, this is why I wanted to see the sagittal view, because it'll give us an indication as to how displaced this comminuted component is. Now, one of the things that we need to decide is, one, is there enough bone stock, and is there a large enough fragment for us to be able to fix it? That's point number one. Because the posterior part, this is a posteromedial fracture complex. Is that correct? It's a more of a medial fracture. Is that correct, sir? Yeah.
So can you go full screen?
Yeah. Can you see?
Full screen in that presentation mode. Yeah.
Oh, yeah. That's better. Yes. Yeah. So it's a posteromedial comminuted talar body fracture. Okay, so that's basically what it is. And the presumption is that the foot was plantar flexed when it smashed up into the tibia. It's a miracle that the tibia didn't break. So the two things that you can absolutely safely assume from this injury is, one is this, the potential for soft tissue injury is very high, and two, that there is substantial chondral injury. Luckily, the chondral injury is well posterior and may not form a huge part in the articulation of the ankle. So what I agree, given the severity of the comminution, potential displacement, and it looks like there might be a die punch fracture as well there.
Yeah.
So I would possibly use a posteromedial approach. I think that's the kind of approach that I would consider doing, because it'll bring me closest to the fracture complex.
Oh, you will go into posteromedial classic one, the posteromedial approach, okay?
That's correct, yes. Yeah. Okay. Is that what you did?
Can I have the opinion of Dr. Bandyopadhyay or whoever is there, Portuzda and Dr. Bose?
Kushal, absolutely.
Kushal also is there.
Ashwin is there?
Yes.
Ashwin Chaudhary, are you here?
Yes.
Okay.
Hello.
So pointed question to Dr. Ashwin Chaudhary. What's your approach to this?
Just one line approach from the CT scan.
Exposure.
I would go posteromedial approach.
Okay. Then Kushal.
I would, provided the skin condition is fine, I'll go medial and osteotomize the medial mal.
Okay.
Medial mal osteotomy.
Who is then Dr. Bose? I think his net is poor.
Dr. Bose.
Dr. Putus Chatterjee is there. Okay. I think that today the net is poor. So there are two views. One is that you can go classic, the posteromedial, or else you can do the medial osteomedial. Okay. So but as because you see the fragment, if I can locate the fragment, it was real. It is not at the front, and it is more or less going to the back side. Yes. Okay.
Hello.
Yes.
Hello.
Yes, I can hear you. So I think
I request everybody to mute themselves except Shaunendu.
Yes. That is the host can do that. Host can do that.
Mr. Tapan Rai, please mute everybody except the speaker.
So I think that as because if you just carefully see the CT scan, it was not on the date. It was not date on the medial side. That's why I went with the whatever Kushal advised. So I went with the classic medial malleolar osteotomy so that I can see the whole medial side. Okay, because if you see the CT scan carefully, there is a lot of comminution on the posteromedial corner itself. So if I go in the posteromedial, I probably can't put the screw in the proper way because I intended the screw. Put the screw on from this direction. Okay, so I did the posteromedial osteotomy. So I did the medial malleolar osteotomy. Now you can see. And before I did the osteotomy, I hold it with the towel clip. And also you can see there are 2 holes because before that osteotomy, I have already make 2 holes for the later fixation of the medial malleolus. Okay. So once I did that medial malleolus, everything was in front. Because if you revert the medial malleolus with your deltoid, and this is the osteotomy, and if you can see the whole posteromedial and the medial side of the talus. So this was the CM picture, and it was not a great deal just to put a screw from that side. Okay. So ultimately, the closure is very simple, and if you see that the screw was from there, because unless you do the medial malleolar osteotomy, you cannot fix this fragment. Even if I am not that expert like Hariharan and like Asin to just put the screw from the medial side. So I did the medial malleolar osteotomy so that I can see the fragment, I can reduce it anatomically, and then I put the screw like this. Any comment, Dr. Hariharan?
Absolutely, sir. That's a great way of doing it. There's absolutely no problem at all with it. I mean, you always have the option of doing the medial malleolar osteotomy.
How you basically my question is that, because putting the question was that how you decide whether this is a medial or the medial malleolar osteotomy? How you decide in your clinical scenario? What is your take on that?
In the clinical scenario, I think it is difficult to work out whether you can, you're looking at an X-ray as to whether, or a CT. I think the CT is probably more indicative of whether you need a medial malleolar osteotomy or not. And if you've quite often, because of this, sorry, if you looked at the CT scan, what I have tended to do was if you dorsiflex the ankle, what you can do is actually bring most of that fracture complex back out to your view, possibly avoiding a medial malleolar osteotomy. But there is absolutely nothing wrong with doing, it's a perfectly safe and legitimate way of doing it. So, you've done a beautiful job there, and hats off to you on that one.
Okay, thank you, Hariharan.
Can I ask one thing, sir? Can I ask one thing?
Yeah.
In your post-operative X-rays, did you notice that there was an AVN? It almost looks like there's a Hawkins sign there.
No, this is immediate post-op. Can I go back? If you can go back, this is not like Hawkins because this is in March. This was done in March. Okay. So if you just say 2016 March, and this patient I have followed for more or less like 3 years, and there was no Hawkins.
Oh, right. Okay. No, that's absolutely fine. If you looked at your AP X-ray, sir, it almost looks like there's some lucency at the top of the. Yeah, there. Yes. That's why I was asking.
This is probably because of the foot position. Because you see, this is because of the foot position.
But one small point, Dr. Hariharan, would you expect AVN in this fracture pattern?
No, you don't expect that.
One of the things that it's happened to me is when you've got an injury which has got extensive damage posteriorly, the likelihood is that you have more injuries. If you looked at the lateral view, you can actually see the fracture line there going almost through the middle of the...
Is someone talking at the back of your presentation area?
No way.
So that coupled with the medial malleolar osteotomy, I have suffered
understood.
An AVN. Yeah.
Okay. No. It was not AVN because I have followed. Believe me, this patient I followed.
Yeah, chondrosis is more of concern than AVN.
Yeah, because
no, but that's what Dr. Hariharan says. No? You can see the lucency, which means it's good.
Yeah, it's good. Exactly.
If you find the lucency, then it is a good sign. This is for the juniors, because if you find a lucency, that means it is revascularizing. Am I correct?
Yeah.
Yes. Absolutely.
Hawkins positive is actually good. It's good news, unlike corona positive, right?
Yes, absolutely. It's whiskey time if you see Hawkins.
So there is a small case like this.
Small?
patient, there is a small presentation sort of thing.
Oh.
The thing is that this lady is around is around 60 years. 60 years. Okay. So she was traveling to Simla for Kulu Manali for a trip and presented to me in my hospital and 10 days after the injury. And if you can see that, this is the this is the clinical picture. And this is the clinical picture on the lateral side. Dr. Hariharan.
Yes, sorry, could I have the plain x-rays back again?
Yeah, back again, yeah.
So you can see that there is incongruence in both the subtalar joint and the talonavicular joint, and it looks like it's a sort of medial talonavicular dislocation, sir, to me. It's difficult for me to work out if there is a fracture or not. I suspect that there might be fractures, but it looks like the navicular has jumped off the talus.
Yes.
And that's why you've got that varus malalignment of the foot.
Dr. Hariharan, this picture I have put for the juniors.
Sorry.
How you teach the juniors and how to go ahead. Whether suppose this was for me, she was there in my hospital after 10 days. Suppose day one you see this patient. What is the teaching for the juniors?
Okay. As always, you check for the fundamental features. You want to check to make sure, because these are associated not always, but quite often with significant vascular damage, particularly if there is a big medial dislocation of the subtalar joint. You can rip off the plantar vessels, the medial and lateral plantar vessels below the medial malleolus. It's also associated with tendon injury. You can get an entrapment of the tibialis posterior or FDL. So you need to be able to make sure that the limb is neurovascularly intact. This is clearly something of an emergency. We need to try and relocate this back as quickly as we possibly can.
Yes.
10 days later is a different ball game altogether. But
yes. The message I wanted to give to the juniors that whenever you find this sort of X-ray, you have to rush into the OT, and you have to reduce this immediately. Otherwise, you are going to probably sometimes even it can end up in amputation.
Yes, because the skin is at grave risk on the lateral side. You already see that there's an area of skin that looks a bit necrotic, and so it is important that we need to relocate it and release the pressure on the lateral side. I think what is also important is how you stabilize it. You can already see there are some blisters there in the near the forefoot, which again indicates that there's been a lot of bleeding. That's right. So we need this needs to be done really urgently. I try and avoid putting K wires in. One of the reasons is that if you do find that there is a fracture on a CT and you need to fix them, you now put a couple of wires in there. So I often would use an external fixator to hold. If you find that it's unstable, I would tend to use an external fixator. Also, occasionally you have to open this. I don't know whether you have seen that. Sometimes the tibialis posterior will prevent relocation.
So this was the X-ray sort of thing. Can you see that X-ray, Dr. Hariharan?
Yes, sir.
So this is the X-ray.
You can see the navicular sitting medially and the talar head sitting laterally.
Yeah. So if it is coming on the day one, that is different. If you receive this in day 10, it is completely different ball game. At least you know that is you are not going to heading towards vascular injury.
Yes.
So the reduction at the 10th day, you should not try, because it is not going to come along.
No.
Anyway. So this was my the question is that to Hariharan, and also all the food guys, how you put your incision, how you take to reduce it.
No, can I say something?
Yeah, Kusal, you are the food surgeon from the east.
No, so before we go into putting knife to skin, one of the more important things that we want to know, are there any associated fractures? Because it's extremely rare to have a talonavicular and a subtalar dislocation at the same setting. It's extremely rare. I don't know whether Dr. Hariharan has seen any. I haven't seen any.
That's why it was put.
So if you can have an idea about if there are any fractures, we can prognosticate better, right? We can tell the patient as to what to expect.
No, it was not. It was not there, because you see, this I did in October 2019. So I have followed this patient till date.
So there was no fracture in the talus.
No.
Okay.
No. There was nothing. You can see the X-ray. But otherwise, I would have told you that was there. Okay.
Okay.
So you can see the subtalar is completely been there. Is not there. Subtalar is totally incongruous. And also, if you see the other X-ray, the talonavicular is sitting completely medially, and everything is gone. Talus is there. So how you put your incision? Medially, laterally, or dead on the front? Hariharan.
Sorry, sir. Can I just go back to Dr. Nag? I think Dr. Nag presumably was asking whether there's any other imaging, like a CT, because I mean, I certainly would have considered doing a CT.
No. There was no fracture. I believe me, CT was there. There was no fracture.
No. That's fine.
No, CT was not. Is not there.
Now, the decision to operate is because this is a chronic dislocation. It's not a chronic. This is not a fresh dislocation.
10 days.
So close reduction is both dangerous and probably unsuccessful. I would use a dual incision approach. I would use a lateral incision and a medial incision. The medial incision is to make sure that the tibialis posterior or any other structures, including the neurovascular structures, are not sitting where when you try and push the navicular back, it's going to jam your relocation. But the lateral incision I found that it is very useful as well, because you will probably need to access not only the talar head, which you might need to push back in because it's a delayed presentation, but you will also have access to the subtalar joint through a lateral incision, which you may need to take out fragments of bone, etc. So almost certainly I would use a dual incision here, sir.
There can be a pseudo buttonholing as well.
Yes.
Not a true buttonholing, but a pseudo buttonholing.
My dear friend, Karthik, I put the incision. It was just in front. Can you see the white structure in front, just below the skin?
Yeah.
Tibialis posterior? No. It was not tibialis posterior. See that? It was the talar head.
It was the head cut.
Right. Okay. So this is the lateral incision. Apologies. I thought it was the medial side. Sorry.
No. This is the lateral because you see your this necrotic area was on the lateral side.
Yeah.
So I decided wherever I feel. Yes, sir.
For the viewers' benefit, would you point out which side is medial, which side is lateral? What is?
This is the head. This is the head. Yes. Because if you see the skin structure, this is the necrotic area. Okay. If you go back to the picture, this is the lateral side. This is the medial side. This is the head side. This is the toe side. Can you see the toes?
Yes.
So this is from that side. Wherever I feel that I could feel the head. So even I put just the skin is that it is not the full thickness one. Still the talus was just peeping me. It was peeping at me. So I have never done this sort of cases because people know me in India like an orthoscopic surgeon. So I did this. So talus was just peeping at me, and I put the incision. Go ahead. And this was the soft tissue. And once I taken off all the soft tissues from there, talus went very nicely on and it was matching on the navicular. Okay. So how you fix it, Hariharan and to Kusal? How you fix it now?
The presumption is that it is quite unstable. I have just simply treated them in plaster because sometimes when they go back, they are really very stable and they don't move out of position. But more often than not, I've tended to use an external fixator.
I agree with Dr. Hariharan. Once it goes back, it's in a very constrained and a contoured space. So unless it's very unstable, which sometimes it is, you may treat him in a plaster. If it's unstable, then of course I would also prefer a fixator instead of KYs.
The reason it didn't go back in 10 days because probably nobody tried that. Okay. Probably nobody tried a reduction. It was untreated, maybe.
Problem is that Professor Kaur, even if you try, it will never go. Because
initially, yes, that's the point. The buttonholing was there. Buttonholing was there.
Problem is that
if somebody tried to reduce it, you'd have to circumvent the buttonholing, which you did by operation. After that buttonholing is taken care of, the socket, as Kushal has said, the socket is quite conforming. So it is very stable. It should be stable. And if it is stable, then yes, plaster is a good option. Or if you are very cautious about your vascularity or maybe the wound problems, then X-Fix is also a fantastic option there.
Sir, I think due to the network problem, Dr. Swarnendu also not there.
Okay. Okay. Swarnant has finished his presentations. So Abhijit is there. Abhijit
Yes,
has
yes,
joined
yes.
back.
Yes, he has joined back.
Okay,
Abhijit sir, please open your video and
Yeah.
Abhijit.
sir, your video is not.
Yeah.
So
now
we can
it's
see
okay.
you, we can hear you. Now we just have to have your presentation on screen. That's all.
Yeah.
Go to the presentation. While Abhijit is fiddling away.
Yeah. Can you? Is there visible my screen? No.
No, it's not visible.
No, sir.
What you are seeing on your screen. Abhijit?
Yeah.
What you are seeing on your screen.
Now it's coming. Yes, sir.
It is in the minimized mode. Just make it a play.
Okay.
It's okay, sir.
Very good.
So there is a network problem. So our topic is that Steffi fast. Can you hear? Can you hear?
We can hear you. We can see your presentation also.
Okay. So how to minimize problems in foot injury? Already Kartik sir told a lot of things in our daily practice. So I just touched something that failing to prepare to fail. So pre-operative plan should be very important for all of us. Gathering and recording consciously all relevant information, planning to minimize risk and maximize benefit for the patient, prepare for adverse event and how to deal with them, and communicate with patient and all members of the team. That is very important. So examination, as already we have discussed, the general, surgery-related, systemic, and specific suitability for the position during the surgery, it is very important. Specific medical and clinical examination to evaluate the presence and severity of the other problem. Diabetic patient undergoing foot ankle surgery need careful examination for sepsis, cellulitis, neuropathy, or microvascular disease. We should always take the HbA1c, preoperative risk reduction strategies should be there. In in our daily practice, it is almost we got diabetic patient, and the minor surgery there may not be need of insulin, but in significant surgery, it should be insulin dependent, and intravenous insulin should be required. Something already discussed during our Dr. Hariharan's speech, that is very important, that plantar ecchymosis. Sometimes we miss this kind of things, and it is related with the midfoot injury, severe midfoot injury, and we should always assess this kind of clinical features who have got this kind of midfoot injury. There is a very debatable issue, the timing of the injury, and especially in our daily practice, we get lot of calcanean fracture around the ankle. So timing is a key factor. So before the blister or the swelling subside, we should always keep the limb in elevation, compression stocking. Maybe for unstable fracture, we need some cast boot. we should always take care of blister, and we can plan the ORI after get the wrinkle sign. The wrinkle test is basically when you get the wrinkle sign to dorsiflex the food and evertate the food. And until and unless you get the wrinkle sign, you should not go for further operation. And sometimes it may be delayed till the third week, but after third week, there should be again controversial whether we go for fixation or fusion like that in case of comminuted calcaneum fracture or like that. CT scan is always tell us. Who are the risks in our daily practice? The diabetic patient, smoker, who has more body mass index, more than 30, aged people. Open fracture is a much more risk, 2.8% risk factor is in open fracture cases. Drug abuse patients are is in risk. So all these things should be keep in mind during our history taking and during our plan of operation. Literature shows incidence wound complication in calcaneal fracture is up to 32%. Heel pad avulsion injury in our daily practice, there is some this kind of things we often get, and it is not uncommon associated with calcaneum fracture. And heel pad is also such a thing which cannot be substituted with the skin grafting. So try to preserve maximum heel pad during the debridement or dressing. Hyperbaric oxygen therapy, which is 100% oxygen at pressure greater than atmospheric pressure for 5 or 6 sessions, is one of the main way of treatment this kind of heel pad avulsion injury. Some facts. Complication. It is in literature stated that extensile lateral approach, which often we use during our calcaneal fracture like that, 29% more chance to get infected in spite of minimal invasive technique, which is maybe infected in 6% cases. That is very much statistically significant. Also, wound complication were 7%, more than 7 times higher in patient with duration of surgery more than 1.5 hours compared to patient with duration of surgery less than 1.5 hours. So, in experienced hand, the risk of infection reduced. Retraction, the fact is that retraction of the skin during surgery. The literature said that there is two kinds of retraction we use. One is static skin retraction, when we put the K-wire drilled in the talus and bent, and another is dynamic retraction. The literature shows that skin complication is much more, 1.59 times higher in static than the dynamic retraction. Another fact is that postoperative drainage. It should be kept in mind that this kind of foot and ankle injury, we should always use the drainage. It reduces the risk. If we not use the drainage properly, the chance of infection increase 8.32 times. Also, closure of the skin. In case of calcaneum fracture, it is always better to do the double layer technique in compared to single layer. And of course, surgeon's experience. Infection rate was 14.3% for the inexperienced group compared to 2.8% of the most experienced surgeon. So already I have said that obese people are in high risk of postoperative complication. So during the operation, what kind of things we plan in our OT? That is always, it is very important to keep the appropriate equipment and instrument should be made available. If there is a comminuted calcaneal fracture and we have to plan for fixation, and if during operation we have to change our plan from fixation to fusion, then we need those kind of appropriate equipment and instruments. So it is always keep all the necessary things in the OT for those kind of fracture. Operating list should be distributed as early as possible to all staff who are involving during operation. Prioritized patient, children and diabetic patients should be operated first. Here is another controversy in foot ankle injury, that is DVT. The incidence of symptomatic DVT, venous thromboembolism following foot ankle surgery is generally low. Early mobilization regimen and the routine use of mechanical measure may reduce the risk of thromboembolism in an acceptable level. Again, the obese, past history of DVT or Achilles tendon rupture need individualized approach for the DVT prophylaxis. Postoperative instruction is always keep the limb elevated and put the patient in rest for 7 to 10 days. Pain management, please take analgesic 2 hours prior to your first postoperative appointment. Elevation is always essential to reduce the swelling. Put the ice pack with towel in foot and ankle for 20 minutes 3 to 4 times per day. Exercise, passive gentle exercise is advisable, and bandage or cast always clean, dry and clean. So postoperative common problem is infection, swelling, bleeding, pain and ill effect of medication. So we should always keep in mind that there may be chance of infection, swelling, bleeding in case of this kind of foot surgery. There is a fact that if the fixation is adequate, so early weight bearing has shown no increase in complication or fixation failure compared with longer period of non-weight bearing and may have improved outcome. Early motion alone may not improve the outcomes as much as when combined with early weight bearing. So this is very important in our daily practice. So with this, I just handed over the mic to Dr. Chichi.
Thank you, Abhijit. Very practical kind of presentation, which we actually wanted from you. The importance is that some of the factors are modifiable. Some of the factors are not entirely modifiable in an acute injury scenario. Maybe in cold case, you can modify for a few factors, few other factors. So in case of unmodifiable factors, you counsel with the patient that because of these particular things, maybe because of the high diabetes or your chronic smoking habits, you have increased chances of having problems compared to a patient who doesn't have those unmodifiable factors. So for the modifiable factors, we are responsible. That is the point of issue in your presentation. And now I invite our faculty to give their inputs, suggestions and comments for the benefit of the viewers and juniors. I'll start with Dr. Hariharan, of course, with Dr. Hariharan first.
Thank you, sir. Thank you, sir. Abhijit, thank you for a very nice presentation. There are a couple of things that I will take umbrage with you. Firstly, I think you've quoted one paper with the 29% and 6%. That is Klein's paper from 2013, which said extensile approaches have got a 29%. Now, I have been doing the extensile approach for 22 years. And I can say with some degree of conviction, if you looked at the Bristol experience, the whole of the UK experience, because the extensile approach popularized in North America is somewhat different from the extensile approach that was popularized by the Bristol group, which is what most of the UK follows. And I can categorically tell you it is a very low incidence, and it is usually associated with comorbidities, the smokers or the patients with microangiopathy or the diabetics. Those are the situations where there are problems with the extensile approach, or in in this, people who have been operated on by surgeons who have taken a very long time. There's a lot of retraction. A bog standard calcaneal fracture, which takes less than an hour to do, I have not come across a complication in the absence of comorbidity. If you read the most recent paper, the Journal of Foot and Ankle Surgery, which is a meta-analysis of over 2,000 patients, comparing extensile lateral approach and the minimally invasive or the sinus tarsi approaches, there is no difference in wound complication rates, no difference at all. And that's a much more pragmatic research analysis. And I would suggest that it's either approach, if you do it well, I don't see that there is any difference, and that has been borne out by the meta-analysis. The second point is you can't use a sinus tarsi approach for every calcaneal fracture, but you can use an extensile lateral approach for virtually every calcaneal fracture. In the less experienced people who want to start out with calcaneal fracture fixation, I honestly believe that you need to learn the extensile lateral approach before you learn the minimally invasive approach, because I believe that that's a far more useful workhorse incision, which allows you to reconstruct the calcaneus and to appreciate the three-dimensional components of it. The second thing is, again, talking to you about foot and ankle wound drainage. Now, I followed that philosophy until about 2010 or 2011. And since then, I have not drained my wounds at all. But what I have done is I completely went away from continuous suture in the foot and the ankle in the traumatic setting. I do not use clips, and I do not use double-layered suturing. Sorry, but that is my viewpoint. In a calcaneal fracture, I use one layer of interrupted suture, and it's usually an Al Gower type suture, where you take full thickness skin, you take subcuticular on the other side, and you come back onto full thickness skin again. It gives you good apposition, and you evenly and widely space out the incision so that if there is any bleeding, it'll come through the incision. After the first 24 hours, if the patient is still bleeding, you have a problem, and you can't use a drainage because it'll pour out. In calcaneal fractures, for example, you could bleed a liter if the patient has got a bleeding diathesis, etc. So I've changed my practice, and I don't use drains at all unless there is an infected scenario. So if I'm treating an infection and I drain, then I would possibly use a drain. But careful single-layered closure with interrupted suture, in my eyes, it's almost negated the need for me to use a drain in foot and ankle injury. Thank you. That's all I have to say.
I have got a question for Dr. Hariharan also.
Yes, sir.
That you have briefly mentioned that there is a difference between the UK way of doing it and US way of doing this extensile approach. What is the basic difference between these two?
Okay, that's an excellent question, sir. I'm glad you asked it. The original Sanders type of extensile lateral approach was on the lateral side, in the horizontal component of the incision. It was almost on the fifth metatarsal axis. Thereabouts. The vertical incision was in the gap between the tendo Achilles and the posterior margins of the fibula. And so the Bristol group worked with plastic surgeons and devised the fact that this incision actually violates the posterior peroneal angiosome. And it's a beautiful series of articles written by the Bristol group in JBJS 2002, 2003, if I remember right. I can't exactly tell you, but it's an article, it's a series of articles well worth reading on calcaneal fractures. The UK incision, the incision is actually far more plantar, and it's at the junction of the glabrous skin of the sole with the skin of the dorsum, and it's almost, it's well plantar compared to the North American incision. And posteriorly, it only briefly traverses that gap between the tendo Achilles and the fibula, and it goes on to the midline, so lying directly on the tendo Achilles. So so if you had the foot at neutral position, 90 degrees in a plantigrade position, your incision will go from about the base of the fifth metatarsal going back almost to the tuberosity, and then will angle at an obtuse angle of about 120 degrees to reach the middle of the Achilles tendon, the midline of the Achilles tendon. What this does is it does not violate the posterior peroneal angiosome. And when you lift the flap off, you take the sural nerve. So the incidence of sural nerve injuries are also very low in the UK version of it.
Okay.
So I don't know whether the camera is holding this, showing this. Maybe this this one is the US version, and this one is the UK version.
Absolutely spot on. You're a much better artist than I am. You got that absolutely right, sir. Well done.
That is for the benefit of the juniors and for ourselves also, because this is getting recorded in YouTube video and we can always come back to it. Thank you.
Fantastic. Why didn't I think of that? Wonderful.
Thank you. Next, we have to have some case discussions. We have cases on talus fractures and talus dislocation as well, and calcaneum fractures and Lisfranc's. May I request Kushal? Kushal, you are here?
Yeah, I'm there. I'm there.
Unmuted?
I was muted.
Unmuted?
Yeah. Unmuted, yeah.
Ready with your laptop?
So let me share my screen.
Yes, you share your screen to show us the Lisfranc.
Yeah. So let me. So I think you can see that now.
Yes, we can.
So I've tried to keep it simple. I tried to keep cases which we get on a daily basis, right? I am not going to focus on rare cases because I think they are good.
Yes, that is the idea. Right?
Yeah, so they're good to discuss, but they really don't add much value to our junior colleagues.
Yes.
So I'm going to talk about a very common injury, which is like Dr. Hariharan says, is very commonly missed in polytrauma setting. You have to worry about the femur and the cervical spine, and after 2 months when he comes back and points towards the foot and say, hey, there's something which hurts me, and by that time it's too late, right? So this has happened to all of us, and I've seen it happen in my hospital also, and it's a fact of life. So this gentleman was a doctor, a fellow professional, was traveling from work to home in a e-rickshaw, which got involved in a collision with some other vehicle, and it tumbled and it turned over and he fell somehow. So and he was and he came and saw me. So he came with the X-rays, right? So so the first thing that anybody would do would get an X-ray. So I'm going to talk about the X-rays like Dr. Hariharan said. So I personally feel that, of course, CT scan is good to have and MRI is excellent. But if you can get the right views, the right X-rays, they really do give us a lot of information than we give them credit for, right? So I think reading X-rays is almost lost art now because we get so many CTs and MRIs now. So you see a AP view, and then you have the oblique view. Unfortunately, from where he came, he didn't have a lateral view, and I think that's one of the criticisms of this case, that we should have had a lateral view. We didn't have it, and I didn't do I didn't do a CT scan because I felt that I had enough information clinically and from the X-rays to figure out what needs to be done. So I'll open this case for discussion with my seniors and colleagues. So what else would they have done, and what is their plan of management? This is a fresh case, and 2 or 3 days later, he came to me. So Dr. Kaur, can you please, spread it around for discussions?
Kushal, open for discussion.
Kushal, am I audible?
Yeah,
yes,
yeah,
you are audible, but you have enough background noises. Somebody is talking behind.
No, background noise is not there because problem was very innate.
Okay.
Okay.
Because so brief comment from Swarnendu.
Yes. Thing is that if you see that this is probably a classic Lisfranc sort of injury. You can see that your tarso-metatarsal joints are completely been disrupted. It is completely been gone to the lateral side. Am I correct, Kushal?
Yes, you're right. Of course,
it is completely gone. There are two sort of classification. I'm going to the detail of that classification. Thing is that whenever I go with the Lisfranc sort of thing, 1, 2, 3, we fix it rigidly, and 3 and 4 and 5, you make it flexible. That is the rule. Am I correct?
Yes, you're right. Dr. Hariharan, would you have anything to add? What are your thoughts on this?
Well, I mean, it's a barn door tarsal dislocation. I would agree with you. I think it's really important, especially if you're not getting a CT scan, is to get a lateral view.
Yeah.
It will basically give you the direction of subluxation in the sagittal plane. So it'll help you relocate it. It's a fresh injury. You're a lucky man, but when you get an injury at 2 to 3 days, that's when it's really swollen like a pumpkin, and sometimes will be blistered. So we need to be careful about assessing the soft tissue components of this before we jump into surgery.
Correct. Yeah.
The temptation is this: you go in quicker, you can reduce it quicker, and I would agree with that sentiment by and large. But at the 2 to 3 days, if you saw the patient within, say, 24 hours of surgery, or even lesser than that, then it's a cakewalk. You might be able to reduce this even closed on some occasions. Whereas if it is swollen up and you've got that, pear-like consistency where you're cutting into organizing hematoma, that's a dangerous thing to do. And I would suggest we leave it for a week, except in circumstances where you think that medial cuneiform is causing problems to the skin, which it can do on occasion. But a lateral view would have been great. I think it's really important here to check the vascular status. I think it's important because, the base of the first metatarsal is probably sitting very, very close to the dorsalis pedis. So it's quite useful just to make sure. If you had a handheld Doppler, you might just double check it to make sure, although you're not going to go and repair it if it isn't, but you can prepare yourself when you open it to reduce and fix it, that you're not clobbering the vessel and causing a lot of bleeding during surgery.
Even your medial cuneiform is probably been fractured, I think.
Yeah. So what I realized, so I didn't do the surgery on the 3rd day. Of course, I did on the 7th day after the swelling had come down, and with tons of ice on him. So it eventually came down. There wasn't any fracture on the medial cuneiform. So and realized that later that there was a dorsal subluxation of the metatarsals, like you said. So it was not a plantar one. It was also, of course, it had to be. If you look at the AP, you can see one of the cuneiforms jumping out from the mortise there, right? From the mortise.
So the lateral cuneiform is flicked out.
Correct.
Yes, Kusal, now I think this is a better picture than the previous one then.
Yeah, so that was the oblique. This is the AP. You can make out that it's out. You can make out the shadow. You can if you can imagine it a bit. So it's out. But the good news this is the AP. So the good news is that the lateral column is relatively undisturbed. This is the medial and intermediate column which are really of concern to us. So once you've decided to operate and fix this, what would be your incision and what would be your choice of implants? Anybody?
Sorry, my practice has slightly changed over the last 4 or 5 years. I tend to use 2 incisions rather than 1 incision. I've gone away from the 1 incision concept because theoretically you could use 1 incision almost centered over the second metatarsal, second tarsal metatarsal joint. You could theoretically get away with it. You can access both the first and the third, but I have kind of gone away from it because there's a lot of soft tissue stripping, which is precisely what you don't want. So I've tended to use either a mid-medial or a dorsomedial incision, and then an incision laterally, keeping at least a 2 to 2.5 centimeter skin gap. I've also changed the way I fix them. I very often now use bridging plates for all of them on the back of work that's been done, including from our very own Vinod Panchbhavi, where, if you can imagine the square, it's at best the second and third tarsometatarsal joint surfaces are probably a centimeter square, with the first tarsometatarsal joint being probably 1.5 to 2 centimeters square at the maximum. And you're going to drill first, and then you're going to put a 4 millimeter cannulated screw in there. It takes out a significant amount of the joint. I don't think it matters so much in the the sedentary or the non-sport population, but I really do believe that it makes a difference in the sporting population. Even though the movement is quite limited in these joints, in the medial and intermediate columns, I do believe that, although I can't give you evidence, and I don't think there is evidence out there to prove that, but using bridging plates for me has had anecdotally, I've had good outcomes for people going back to sport.
Yeah, so yeah, I think I said that's a very good point, and I agree with you in a way. So I also like to try not to go through the joints as much as possible and preserve whatever articular surface I can. And of course, in this case, I started out with also medial incision, and then of course went and did a slightly more lateral incision with keeping 2.5 centimeters of skin between, because I realized that you couldn't reduce the sublux lateral cuneiform from the medial side.
Precisely,
so
yes.
it was a dual incision, and I did just that.
Perfect.
So I used bridging plates. The X plate wasn't available with me at that time. Otherwise, I would have loved to use it and get rid of the screw which I had to use to mobilize or to immobilize the Liszt trunk joint there. But I've realized.
Can I just interrupt, Kushal? I think you've done a great job with that screw, because you've actually only breached the articular surface very laterally.
Yeah.
Large proportion of that articular surface is still intact. So that's actually quite a clever way of doing it. My only question to you is, I've not seen a screw used in this direction. I've seen a screw used from the second metatarsal onto the medial cuneiform. I'll just ask your logic on why you've used it from the first metatarsal into the intermediate cuneiform. Did you think that was going to keep that intercuneiform gap under control? I'm not able to understand.
Yeah, I was
why.
trying to mimic the biomechanics of the X plate, right? So I wanted to, so the two poles of the plate, right? The two X's. If you imagine the screw to be one of the axes of the X's,
right?
So that's what I was trying to mimic. Trying to put a screw in the intermediate cuneiform and one in the first metatarsal base. So, and to do that, I had to put the screw this way. So what happened was, once I put the screw in, the movement, the laxity stopped, right? And of course, I agree with you. It could have been done maybe more elegantly with an X plate, so that you don't have to violate the joint at all. But I think one of the more important criticism of which I was not very happy with was maybe I could have used a longer 2-hole plate on the third and lateral cuneiform. That's something, though I had reasonably good hold, but maybe I could have used a longer plate.
The other point I wanted to, sorry, go on.
Did the patient have a comminution at the base of third metatarsal?
Yeah, so that's what I was referring to. Maybe I could have gone, but I had good hold there. That's why I didn't revise it, but the X-ray would seem otherwise. So maybe to stop any controversies, maybe you could have used a longer plate. But this was, I think, the longest that I had at that time. So I could have used those hand plates, the smaller ones, which you used in the metacarpal plating.
So the screw diameter was?
It's 3.5. It's the matrix system.
Okay.
I still go back to the point that I made earlier, Kushal, just for the benefit of the juniors and the younger surgeons here. The traditional methodology of fixation is to recreate the Liszt-Franck axis, the axis of the Liszt-Franck ligament, which goes from the base of the second metatarsal to the medial cuneiform. My concern would be that the screw from the first metatarsal into the intermediate cuneiform, because there was dislocation of the second tarsometatarsal joint, it may not be enough to keep the first intermetatarsal gap under control. Ideally speaking, I would have probably used an auxiliary screw along with the plate from the base of the second metatarsal into the medial cuneiform, which is the logical anatomic reconstruction, if you want to use that word. I somehow hate that word. The second point is the plate that you've used in the third tarsometatarsal joint will not in any way stabilize the loss of ligamentous laxity between the intermediate and the lateral cuneiform.
Correct.
Do you get what I'm saying? Because it's the lateral cuneiform that jumped out, isn't it?
Yeah.
So what I have tended to do in circumstances such as that is I put a screw from the medial aspect of the medial cuneiform all the way across into the lateral cuneiform. So it keeps the three cuneiforms in place, and I take that out at about 4 months or so, just so that we get some mobility back. So these are not criticisms, but just observation.
Yeah. So next time, before it's nice to have a fresh perspective, right? I mean, next time you do it, you can at least think along those lines, right? I mean, it's nice to have a new perspective. So, Dijida, so I think we are done with this case. Is there anybody any questions, or you can go to some other thing? I mean, up to you. So this is basically
now I can't find any questions here. Yeah. But your last slide is coming up. This is the follow-up X-ray.
This is the follow-up X-ray. This is that surgery was done in December last year. So this is basically X-ray of
6 months.
May. Yeah, 6 months.
6 months. So and how is the patient doing?
So this gentleman is happy. The only complaint he has now, he calls me up other day and says that screw head is protruding a bit. So I might have to go in and check it out.
Okay. Yes. Prominent on the skin. Yeah, that is the only issue right now. And he is working.
Yeah, he's joined normal duties. He's doing his COVID duties. He goes to a health center in West Bengal, so he's happy. So that the only thing is bothering him. So I'll have to take this out.
That's a fantastic result, at least short-term result. And I do not think that the short-term result will become worse in long term. Let's hope with that. And we can have next case is another Lisfranc to have some comparison here from our Dr. Bappaditya Ghosh from Malda. Bappaditya, are you ready? Bappaditya, can you present from your end?
No, sir.
Okay. So I have to present your.
Dr. Ghosh, you just come in front of the camera. Yeah, it's now okay.
Okay, Dr. Ghosh is in front of camera. And I'm sharing my screen over here. Okay, so this one. Can you see the screen of
yes,
Dr. Bappa Ghosh's presentation here?
Yes.
Can you see? It's in the minimized mode. I'll go to the play mode here right now. Can you see the screen? Can anybody see the screen?
Yes, it's visible, sir.
It's visible. So over to Bappa, you present your case and let me know when we have to change the slide. I'm acting as your assistant over here.
This was a 25-year-old male patient. He had a bike accident and he presented to me 3 days after that. There was pain and swelling around the right foot and forefoot, and the patient was unable to carry weight on his feet. And the next investigation we do was a X-ray. Okay, this was the X-ray that I got at the time, and unfortunately, I have not done a lateral. And from X-ray, I can see that there is a cross location of the fifth tarsometatarsal joint. There is a displaced fracture at the neck of second and third metatarsal, but no gross dislocation of first, second, third, and fourth metatarsal was seen. But there was tenderness at that area, and swelling was also there, and plantar ecchymosis was there, and so I thought that there may be some Lisfranc injury in that area also. So I did not wait for any other investigation because I thought that X-ray is enough for diagnosis, and I have to see the stability of the first, second, third, fourth metatarsal during the operation under image and intensifier under anesthesia. So after counseling, and there was only moderate swelling. So after 3 days, I went for operation. Patient was taken to operation. And next slide, please. And this was the picture during operation. Under image intensifier, we saw that all the Lisfranc joints were unstable, and so all the two incisions were made, one medial and dorsomedial and one dorsolateral, and dorsomedial incision. First, second, and third metatarsal fixation were done, and from dorsolateral incision, fourth and fifth tarsometatarsal fixation was done, and all the fixations were done in an open method, and neck fractures were fixed percutaneously. Next slide, sir. This was the post-op AP X-ray, and next slide, sir. The next. This was the post-op lateral.
Oblique, you mean?
Hey, sorry, oblique.
So any comment from the esteemed faculty on this? These two. This is the oblique and this was the AP.
Comment is that Professor Kaur, can you hear me, Professor Kaur?
Yes, I can.
The thing is the thing is that whatever Dr. Bapaditya has done, this is excellent, and this is the crux of the story. That whenever you do the lateral side, that has to be fixed with only with a KOF. Never put any hard implant on the lateral side. Am I, Dr. Horiharan? The medial side I am not commenting, but the lateral side is excellent.
Yes, I agree with you. I think, again, I have gone away from putting intra-articular or transarticular wires, but there is no harm in doing that. I mean, all the published literature would suggest to you that you need the mobility. The lateral column is a very mobile column, and you need that mobility in order to accommodate for irregularities on your walking surface. So you need tarso-metatarsal mobility in the fourth and the fifth, and so you only use temporary fixation, and you can take it out at 6 weeks. I have tended to go, again, I tended to use external devices. I use just, mini fixators. They work very well. And there is no comorbidity associated with the actual articular surface. Just trying to work out, you've used 3 screws of one larger diameter and 1 small diameter screw. I'm just trying to work out what your thought processes were in using it in that configuration. Again, I go back, you did a great thing in screening it, and I use that technique very often, because even an MRI scan doesn't give you the real-time information, the dynamic information. So there are 2 ways of doing it, and I've seen colleagues who would inject the tarsometatarsal joint complex. So you give 1 injection into the medial side and it filters right the way through, and they use an ultrasound scan to see if the TMT joints are displacing. Now, I don't use that. I just take them to theater because I'm going to stabilize them in any case. And I would screen them just like you did. Sorry, sir?
A kind of arthrogram then?
No, it's not. It won't be an arthrogram. They use an ultrasound scan because you can twist the foot. Once you've anesthetized them, you twist the foot around, and a good sonographer can tell you if the joint is subluxing or not. And, I'm not familiar with it. I've only heard other people doing that. But once you have done that and you've determined that there is instability, we'll have to go back to what the basic is. Where is the Lisfranc joint traveling from? It's traveling from the base of the medial cuneiform, base of the second metatarsal to the medial cuneiform. And that is the axis that you're trying to recreate. And Vinod Panchbhavi, again, did this study where he put a screw from the medial cuneiform to the metatarsal, and then did the opposite from the metatarsal to the medial cuneiform. And he was right in saying it's better to push the second metatarsal against. That's correct. That should be the direction of travel. So it's better to push the metatarsal with the screw head onto the medial cuneiform rather than trying to pull it from the medial cuneiform. So I think we need to make sure that you've got a good screw purchase into the medial cuneiform. Can I ask why did you decide to use a tiny screw in the second? I mean, it sounds like an interesting idea, but I don't know what your reasoning for doing it. If you were,
if I use a 3.5 screw, there may be a fracture. A fracture may occur at third metatarsal base. That's why I
Right.
use this 2 millimeter. But later I found that I could have been using 3.5 millimeter.
Yeah, right. Okay.
I think that would be better.
Yes, I think I would agree with that. You know, this bit is actually relatively easy compared to fixing those bloody metatarsal head fractures. I find them a terrible nuisance. If you belong to the IFAS WhatsApp group, Dr. Mahesh Soni gives you a wonderful technique of how you use these intramedullary wires to reduce these fractures. It's well worth having a look. I don't know where Dr. Maheshwari is from, but he's a foot and ankle trauma surgeon practicing in India, and he puts up some wonderful photographs. One of them is a series of metatarsal fixations, and I think it's very important that you fix those, because if you don't fix those, it's very difficult to reduce the tarsal-metatarsal joints without them sort of floating everywhere. So I think you did very well on that front, but I would certainly rethink the options of fixing the metatarsal to the medial cuneiform, independently stabilizing the first tarsal-metatarsal joint, and possibly using a bigger screw, as you've rightly said, and a bigger screw is probably a good idea.
So the one point of learning from this case of Dr. Bapaditya Ghosh is that there can be occult instability.
Yes. And I think that's one of the reasons why you CT scan them, because I've discovered to my anguish that I had missed a navicular fracture once, and that was bad news for me because the patient came back with AVN of the lateral navicular. Because I said everything is fine, your Lisfranc joints look wonderful, but I'd missed a navicular fracture. So I almost always get a CT scan because your point is absolutely right, because of the possibility of occult fractures.
Yeah. So if the patient cannot bear weight, if there is a plantar bruising, we should have very low threshold for prescribing a CT scan.
Right. Absolutely right.
Okay. So shall I proceed to the next slide? Oh, that was the last slide, Papa. So you have finished your presentation. We have seen 2 cases of midfoot injuries. Now you can move to another domain, that is calcaneum. Dr. Bose, you are ready with your net connection? Dr. Bose? Dr. Bose is there? Unmute yourself. Dr. Bose, please unmute yourself. We cannot hear you.
Can you hear me now?
Of course. You have unmuted yourself and we can hear you. Would you like to present from your laptop? Would you like to present from your laptop or what? Can I help you from my end? Please unmute yourself once again. Dr. Bose.
I've unmuted myself.
Yeah. So would you like to present from your end, your laptop, or I would help you here?
No, you show me from your, you share the screen.
Okay. So let me have the screen first. Get your presentation uploading.
Whilst we are waiting, Dr. Carr, can I ask the panelists, again for the benefit of people who are listening, if you had a severely comminuted fracture dislocation of the Lisfranc variety, how many of you would be tempted to do a primary fusion?
I would pass that question to Ashwin, who is almost muted till now. Ashwin, you are here?
He is not here.
Okay. Huh? He's not here?
No.
Oh, maybe he has also some problem.
Let me take that.
Then,
I think that's
yeah,
a very very controversial topic. I don't know what the current consensus on it is right now in the UK, but I mean, I would be tempted if it's a severely smashed Lisfranc. But having said that, I would rather try to preserve it in the first go, but counsel the patient that eventually he might end up with a fusion. What I'll probably do is to try and keep a maintain the biomechanics of the foot, right? I mean, with severe dislocations and comminution, maintain the biomechanics, let the soft tissues heal, let things settle down. Because by definition, if I have to fuse the Lisfranc, I would have to use some sort of a internal fixation, right? And most of these severely comminuted Lisfrancs usually have some amount of compounding. So I think it's a very interesting question. But
I'm trying to share my screen over here.
But I haven't done any, right? I mean,
no,
I was tempted, but I haven't done any. I don't know, Dr. Hariharan, I think he would have done quite a few.
No, not quite a few. I mean, I'm also a bit like yourself. I'm a little careful about rushing into fusion, but I have done a few, and I have to say that the results were actually very pleasing. But I would agree with you in an environment where everything is compromised. Why ask the body to do something over and above what it would normally do? And that's the reason why.
Yeah.
We can have a chat about it if you've got time at the end.
I haven't really done anything about that, but I don't know. Someday maybe I have to do that. I haven't had the courage to go and do a primary fusion yet.
Now let me go.
My time will come.
Presentation of Dr. Guy Bosch. Can you see the screen? A case of polytrauma written at the top.
Yes, sir.
Okay. So, Dr. Bosch, the stage is all yours.
There is a case of polytrauma. It is treated in some stages. Now, this happened 10 years back. A patient aged 40 years was admitted in a nursing home following a motorbike accident. He was in profound injury. Next slide. A degloving injury of the heel with open fracture of the right calcaneum. Degloving injury of the heel with open fracture of the right calcaneum, and you can see there is a tuberosity fracture, avulsion of the tuberosity fracture. I'm asking to the panel, what are the options now at the primary? Next slide, please. Next slide.
Okay, as you have already disclosed in the title that it's a polytrauma case, which surely like to have the assessment of other injuries. These are the other injuries.
There is either fracture of the medial corner of the right tibia, trochanteric fracture, fracture of the distal third of the right femur.
So all the fractures on the same limb, same side.
Next slide. Hemoglobin alarming 6%. Oxygen saturation.
Speak louder, please. Bapada, jore.
Stage 0. Resuscitated by 4 units of blood and plasma expander and bypass ventilation.
স্যার আপনার হেডফোনের এটাকে একটু মাইকটাকে একটু কাছে নিয়ে আসুন। ডক্টর বোস আপনার হেডফোনের মাইকটাকে কাছে নিয়ে আসুন, সাউন্ডটা খুব কম আসছে।
হ্যাঁ
হ্যাঁ এবারে ঠিক আছে, এবারে ঠিক আছে। এইভাবে
hemoglobin alarming 6%, oxygen saturation was 88%, semi-conscious stage 0, resuscitation by 4 units of blood and plasma expanders and bypass ventilation. The wound was covered with sterile dressings. Now I am asking to the panel, what should you done? Back please, Gigi, back.
At this stage,
what should be the plan now?
For the
to the faculty, what should be the plan?
Sorry, sir, I didn't catch your question. Is this the plan for the calcaneal fracture, the polytrauma, or the general state? I mean, my immediate plan would be to try and keep the patient alive. Massive attempts at resuscitation, temporizing stabilization of fractures if required, splintage, external fixation, whatever it takes. My immediate plan would be to try and keep the patient alive, resuscitate him, and primary wound toileting of the tuberosity, appropriate coverage with antiseptic dressings, etc. And then assess the patient in the light of what his general status is as to whether he's actually fit even for a haircut. I think that from the point of view of a protocol, that is what I would tend to do. The most pressing problem in his situation is hypovolemia and shock. And, once the patient is stabilized, then I would start to prioritize how I'm going to fix. Did I hear you say that he had a pelvic injury, or was that just a proximal hip fracture, sir? Did he have a pelvic injury?
No.
No, sir.
No. Okay. So he's got a hip fracture, which really does require fixation fairly early. I'm not too worried about the tuberosity fracture, to be honest. I mean, that is something that you can plumb back quite a straightforward manner. But if you want to temporarily fix it with either an external fixator or some wires, that's not a major issue. But I think primary wound toilet, copious lavage, all of that is probably really important, and a definitive fixation can be undertaken at some stage. I think the femoral fracture is probably a priority. The plateau fracture, I think I'm quite happy to wait until he stabilizes, but I would like to stabilize the femoral fracture, the shaft and the hip fracture, because it is basically a segmental femoral injury with a high propensity for fat embolism, etc., acute kidney injury, and all of those complications. So that would roughly be my plan. It's not going to be easy because you've got the plateau fracture on the same side in addition. I haven't done general trauma in almost 16, 17 years, but the idea would be to try and fix the femur either with an intermedullary nail and then externally fix spanning the knee, maybe. I don't know what the current trends are there. I'm not the expert on that. So that'll be my plan, and I would probably leave the heel for after these preliminary procedures were undertaken. That's what I would do.
Okay. So the point of learning from these cases is that there can be a plethora of injuries, plethora of bony injuries, as well as some other systemic injuries, maybe because it is a case of polytrauma has been mentioned in the title. So there should be at least another system of injury, system got injured apart from the musculoskeletal system. So the priority is the damage control orthopedics. That's what we mean, right? And then we proceed.
Yes.
Stage one.
So then the next day, so stage one, K-wire fixation of the tongue and the ankle spanning external fixator was applied. And at that time, when I worked in a very rural setup, so at that time everything was not available. So I applied a distal femur skeletal traction and put them in a Bohler bronze splint, and the limb was put up on a Bohler bronze splint, because at that time X6 system was not available in our setup. So that was it was about 10 years back. So I did that. So then I dressed and I stabilized the fractures. Next slide, please. Gigi, next slide, please.
It's already there. Next slide is already there.
Stage 2 after 5 days. Yes, after 5 days, close sinus nail closed Cyrus nail for the fractures of the femur, and the T-plate of MIPO fixation of tibial fracture was done. Next. No. Stage 3, after 2 weeks, his wound was treated by plastic surgeon by reverse sural artery flap.
Shall I proceed?
Proceed.
Okay.
Knee bending exercises was started from second postoperative day of stage 2. Non-weight bearing crutch walking was given after 1 month following removal of external fixators. Partial weight bearing was allowed after 2 months. Full weight bearing was permitted after seeing good amount of callus. Next. Now this is the clinical pictures, and during the sural flap, another K-wire was passed, and at that time you see the subtalar joint is distorted. Next slide. Proceed. Proceed, Gigi.
I have given the slide.
Yeah.
You are seeing the next slide with the final radiological and clinical pictures of the limbs. Okay, around the hip and the knee. Can you see that?
This is the final radiological picture.
Yeah. The neck has united, the shaft, I think, has united, and the medial tibial plateau has united, and he's having visible range of motion of the knee joint. That can be seen from these clinical pictures, and this is how the patient stands. Okay, that was the last slide. The standing patient over here. So, Dr. Bose, this is the final.
Yes, this is the final.
Picture. This is the final picture of the calcaneum.
Yes, after I removed the K-wires after some time.
Okay. Did you have any recent follow-up? Maybe after, say, few years.
Yes, actually, I took the photograph, the standing photograph recently when he came to for the removal of the wire.
Okay.
He came for the removal of the wire. He came for removal of the wire after 8 years.
Okay, for 8 years.
8 years.
That's an issue in itself. Removal of implants after 8 years.
Yes, he was not very much. He came after 8 years, and at that time I took this X-ray that fracture has united, because he was.
So we have another calcaneum fracture lined up. We have another calcaneum fracture lined up from Kushal. Kushal will share his experience with that particular fracture. Then we come back to our esteemed faculty about these two different types of calcaneum fractures, right? So Kushal, are you ready? Kushal?
Yeah, I'm ready.
You are ready? I am stopping sharing my screen so that you can do that.
I think this is quite a simple textbook case in a way. The idea behind this was to discuss certain points of value to our colleagues. A policeman who was up on the wall of his housing complex doing something funny, trying to get some mangoes out of the tree or something.
Oh, not catching a thief.
Yeah. So he was not in the line of duty at least. So so he slipped and fell, landed on his heel, and immediately sustained. He knew he had a fracture. Quite intelligent guy, huh? Young police guy, intelligent fellow. So of course he came to me after 7-8 days, right? So it was already 7-8 days, good 7-8 days after the injury. So by the time he came, I mean, so he came with these X-rays, right? I mean, so and the reason I'm putting up these X-rays is one of my favorite bugbears. You know, I mean, if I have to play the devil's advocate, I would be asking Dr. Hariharan that you don't need CT scan for a calcaneal fracture. How does that sound to the panelists? You need good X-rays. How would you react to that?
Kushal, it's an interesting point. It depends on the fracture, I think. If you've got a pure avulsion fracture, even if it is intra-articular and it's a low velocity injury, you know, patient was climbing up the stairs, felt something pop. That's basically an Achilles tendon injury with a chunk of os calcis attached to it. However, if there is comminution, one of the problems that I have is I'm a bit old-fashioned. I need to know how many fragments there are. Is the anterior part of the os calcis intact? Is there an extension into the calcaneocuboid joint? What is the state of play of the medial wall? I know you've got axial X-rays, but for me, I need to know, is it a Saunders 2 or a Saunders 3? And very often you'll find just from a lateral view X-ray, you may not be able to pick up those subtle features. So every single time I've taken a CT of an os calcis fracture, I found a lot more than what I thought that the patient had. And for those reasons, anything apart from an avulsion injury, if I'm looking at fixing a fracture, I would like to get a CT so that I get a three-dimensional view of what I'm looking to reconstruct. That is a personal viewpoint. And I think if you ask a reasonable body of orthopedic surgeons, I think the answer would be somewhat similar.
Yeah, I think
it's a case-to-case basis.
Yeah, so I think the teaching over the years has evolved into a phase that, you know, right now what the message that goes out is you can't fix a calcaneum fracture without doing a CT first. And I'm certainly uncomfortable with that statement. You know, I mean, a CT helps, but it can't be that without a CT I won't attempt to fix a calcaneum fracture. And going back to Dr. Hariharan's point, and he pointed out quite correctly, right? I mean, when you start doing a calcaneal fracture, you must be comfortable doing the extensile lateral approach. And if you're somebody who does a reasonable volume of calcaneal fractures, you will realize that once you have done an approach and opened up the flap, you can see very well inside what are the fragments there. Of course, you can't see the CC joint, but that well. But so from the articular perspective, you can see the fragments, you can see the comminution. So it's not that difficult. But I take your point. But I did a CT, of course. I didn't. It's not that I didn't. But before we go to a CT, this is something that a lot of my colleagues will want to know. How much of a swelling is a problem? Sometimes it's very difficult to quantify, and I don't really have numbers or a classification or something to really tell you objectively what exactly is something I'm comfortable with. But when I see a foot, I look for these wrinkles, right? If I can see these wrinkles in these form, I am reasonably happy that I can go ahead and not burn my fingers. If I don't see these wrinkles, I'll still wait, and I'm happy to wait for 2 weeks or maybe 17, 20 days. You know, I rather work a bit
as
harder.
Abhijit has pointed out.
Yeah, I rather work harder in the OT than regret later. But if I see those wrinkle signs, I am reasonably happy that I can get away without a skin complication. And coming back to Dr. Hariharan's point, he made an excellent point about the incision. You know, it has to respect the vascular plane. I've seen so many fractures, so many incisions which are quite proximal. You know, even more proximal to the dermoepidermal junction there, right? And they have a terrible skin problem. So we have to be, and it doesn't matter whether the edge of the incision is curved or round. I get a lot of questions whether it is round, it should be round, or it should be pointed. I don't know whether any one of you have a different opinion, but I don't think it really matters. You know, anybody want to jump in on that? I'd be happy to apply.
No, you're absolutely right. It really doesn't make any difference. For a long time, I had an acute, sharp, edged, angled incision, and then I moved to a curved incision. It really doesn't make a difference at all.
Yeah.
I think it's a bit more difficult to suture a curved incision.
Yeah. Yeah. With the pointed one, you can actually match the edges. So it's much easier
Yes,
that way.
exactly. Yeah.
So anyway, so going to the CT scan, of course, I got a CT done, and this is what it looked like. I mean, these are the sagittal views. These are the axial views. So you see, it's a decent amount of comminution, but reasonably well maintained articular congruity. So any further pointers on this? The panel, anybody?
So Kushal, this proves my point about from your earlier question about should we do a CT or not. If you go back to, I mean, you don't have to do that, but if you looked back on that lateral view, you would never say that the CC joint was involved, would you?
Yeah, you're right. You would never. So if you look here,
you looked here, it is very obvious that the CCJ is involved here, and that Stefan Rammel's work, Hans Zwipp's work, shows that involvement of the CC joint has got an important prognostication that the results are likely to be worse. And, it is something that you'll have to tell patients, particularly in the present era where they want, patients want you to be a magician with a crystal ball and tell you exactly what's going to happen for the next 50 years. I think from that point of view, this absolutely proves my point. It looked like a tongue-type fracture, one fragment coming off, but if you looked at your coronal and axial sections, you'll see severe comminution. There are at least three fragments to the posterior facet of subtalar joint, which proves my point that it's almost always worse than what you think it is on plain X-ray.
Yeah. So
the Sallingeris, there are big chunks on the medial side, so that you can have your support for the screws.
Yes.
Purchase for the screws.
Yeah, but I think Dr. Hariharan is right when he says this. So it always is worse than it looks on the X-ray. I think it helps a lot, particularly with the modern outlook of looking at whether your CC joint is congruent, whether you're, So there are a lot of other things we have to address nowadays because new research has shown that results can vary. So in that perspective, yes, it helps. But then what happens is, and I'm not being, I'm not being critical of anybody. Many of the times I see CT scans being done, it's just done for the sake of doing. I mean, I don't see any critical appraisal or thinking through that. And it's maybe our fault that we are not taught to look through what to see in a CT, in a way.
Absolutely. So I don't know whether you've seen any of my talks on calcaneal fractures, Kushal. The one thing that I emphasize, I said, what the CT does, whether it helps you in deciding whether you're going to operate or not, or what kind of operation you're going to do, what the CT actually does is help you understand fracture behavior. Fracture patterns. And I sit with the CT scan almost every case. I sit with my trainee and say, I want you to tell me, describe the fragments to me. Where is the lateral joint fragment? Where is the sustentacular fragment? Where's the anterolateral fragment? If this anterolateral fragment is very displaced, would you fix it separately? I think what it allows you to do is to discuss the fracture so that you can almost decide where you're going to put your screws, what kind of plate you're going to use.
Exactly.
And I think that's the reason why I agree with you. If you've got a completely undisplaced fracture in a diabetic smoker that you're never ever going to fix, it's a crazy idea to CT. It's an idiotic thing to do. But if you are contemplating fixation and you are looking for additional information, this is the Rolls Royce of investigations for all hindfoot injuries. I think the pilons, the talus, as well as the midfoot, of course, but in the hindfoot, it comes of its own because what you're then able to see is a 3D version in your head. Even if you had great visualization, you take the lateral joint fragment out and you're going in to the body of the calcaneus. If you didn't know what the medial wall looked like in its entirety from back to front, it's actually sometimes can be quite a tricky thing, especially if there is a huge overlap and you're trying to uncouple the two plates of the medial side so that you can reconstruct the medial length. It actually is really quite difficult without having had that information. You're then there fiddling about for hours with periosteal elevators saying, how the hell am I going to reduce this?
So what actually a CT does, you can actually, like Dr. Hariharan says, you can actually think about it the night before. I actually play out the steps of the surgery. What are the fragments that I'm going to fix? Do I put a screw in the anterior segment? I mean, there's a lot more to it than a simple CT, right? I mean, and it's happened to me. I've often found it difficult to reduce the middle fragment, right? That the one sitting in between because it's impacted, and I can't take it up. So it really makes a big difference if I know how many fragments are there, exactly do I put a separate sinus tarsi screw, or do I put it through a plate? I mean, these are the few things that helps me plan, and it helps me improve maybe my results. I mean, I'm sure there are many people who do it better than I do, but it gives me some peace of mind to know that I know the beast that I'm going to fight with tomorrow, right? I mean, in a way.
So in this particular case, what was the reproach?
So if you look at the CT scan, like Dr. Hariharan says, you can actually find out not occult line. It's quite obvious break in the anterior process of the calcaneum. So which means you have to put one screw at least through the plate in the anterior process. Otherwise, it's going to float around, right? And not going to put it back properly. So once you have reduced the subtalar joint and you've got the fragments back up, you need to also look at those peripheral joints and see whether they're well aligned, whether they're reduced. And if you look at the actual view, one thing you have to be very careful about is the middle fragment.
You can use your cursor.
So what happens if you look at the middle fragment, right? This is the part which will really trouble you, and this happened to me. So what I often do, I take off the lateral wall, and put it on the table. I can see much better. I try not to do it I try to do it gently and not rip off stuff in a way if I can't, and take it up so that it helps me reduce the joint properly and not miss out those steps in between, right? Because it's difficult to see reduction properly in the axial view in the C-arm, in the OT, depends on the technician, the machine, and everything. So these are the two things that we need to watch out for: the fragments here and the anterior fragment here. So you see there's a fracture there. We need to. These are fragments here, right? You need to buttress those fragments and put it back in place. So 2 or 3 issues that we need to be careful about, and also maintaining the height and the alignment of the tuberosity, which is of course something that we all do quite routinely. So this is what we did, and this is what happened. So I intentionally put a medium-sized plate, longer plate, because I wanted to put one screw in the anterior process so that I can hold it in place. And of course, I have often put separate sinus tarsi screws, because I've often noticed one very important fact that the screw through the plate isn't exactly a proper sinus tarsi screw. You can make out from the X-ray, it's not a proper sinus tarsi screw. So I would be more happy if I could put a separate screw, through the sinus, a 4 mm screw through the sinus tarsi and into the sinus tarsi. But in this case, the fragment was too small for me to put a separate screw, so I didn't. But I would love to do that first and get a good hold on it, and then put a plate to buttress it.
Sorry.
So what is the follow-up?
Can I just? I don't understand. You put a screw into the sinus tarsi?
No, sorry. A screw.
A lag screw. You're talking about a lag screw fixing the lateral and medial components of the joint, is what you mean, right?
Yeah. So yeah. Sorry.
Okay, great. That's fine.
So what is the follow-up of this case?
So this is just 2 months. Well, this is the 3-month X-ray. Started walking now.
Okay.
This guy started walking now. So I initially allow partial weight bearing and then transition to full weight bearing in a month's time. But the point to make out is to maintain the alignment and maintain the proper height of the heel, and also not to ignore the CC joint, and you don't need to put in too many screws. So if you look carefully, I put 1, 2, 3, 4, 5, 6 screws here. You don't need to put screws in all the holes. So the buttressing effect takes care of it. So I think this is what I did. I think I will be happy to hear out what else we could have done and how could I improve what I did here.
I think you've done a great job. I think the 3 tenets are, as you rightly said, recreate Bowler's angle, because we know there's extensive research that's been done, the big meta-analysis, and Bowler's angle was perhaps the best indicator of what your outcome is going to be. The more severe the depression of Bowler's angle, the poorer the results. And there's a direct linear correlation. So recreating the crucial angle of Gissane and the Bowler's angle, recreating, like you've really nicely done, the axial alignment from back to front. You've got that lovely axial view there, which shows that the axis of the heel is neutral. And thirdly is the height. As you say, you have to lift up that depressed a lateral joint fragment and try and pull it all the way up so that it's congruous. What I would often tend to do is in the immediate or in the perioperative phase, when you screen the fracture fixation, I would almost always try and get a Broden view, because I have been caught out. One or two of my screws will broach the either the joint or the sinus tarsi or the tarsal canal. So, I used to do CTs in the past because patients say, well, it's still hurting, it's a bit stiff. Some of them you get away with, even if, if there's part of the circumference of the screw that's broaching the joint. Bizarrely, you seem to get away with. And I think it's because there's not much movement in these joints, even after you've fixed them. And as long as they're stiff and pain-free, you're okay. But some of them hurt. And when you've done a CT, it's quite it's humbling, really, when you see, oh my God, I've put a screw into this joint. So I almost always will get a subtalar view just to make sure that my screws are nowhere near the joint. This is just a
I think I'll do that next time. Yeah, I think this is a very interesting point that you made, and I don't really do that, but I think I'll try and see if anything what you're saying. I'm sure there will be surprising findings, right? I mean,
yes.
Yeah.
When you start CT scanning them, that's when you realize.
Do you use bone grafts or any bone substitute?
No, I don't. I don't think there is any role for that. But I don't know whether Dr. Hariharan, are you using any?
Never used bone graft at all, except when it was an infected non-union. Then I did go back. When it was an infected non-union, I used synthetic bone substitute with antibiotic in it. But I've never used bone graft.
Okay.
Because it's the whole of the calcaneus is just a giant venous sinusoid. It's so rich in vascularity. Even in patients who have got vascular compromise, you'll find that a calcaneal fracture will bleed if you go and operate on it. So its osteogenic potential is so high, you really don't need it at all. Patient's is not going to be walking on it for 6 weeks. And if you get a CT scan at 6 weeks, you'll actually see fantastic healing of the fracture. Sometimes the fractures are fully healed at 6 weeks. So I've never used bone graft. Even though there's a big hole, I've never used bone graft.
Yeah.
What an interesting case from Kushal.
What are the faculty's opinion about the gest fixator in fractured calcaneum in depressed? Any clue about that, Kushal, or any
I've
other?
never used it, sir. I'm not a big fan of that, but I'm sure it has its uses. But I've never used that. No, I have no experience with that.
Non-invasive kind of thing. Okay, can you stop sharing your screen so that we can go back to Bappaditya Ghosh from Malda? We started our case presentation with the talus fracture from Dr. Swarnindu Samanta, and we'll sign off after the last one is also a talus fracture. Bappa, are you ready with your system, microphone and all that? Dr. Bappaditya Ghosh? Shishandu, Dr. Bappaditya Ghosh is online?
He is there, sir. He is there.
He is there.
Dr. Ghosh. Yeah.
Bappa, are you there?
Yes, he is coming.
Unmute yourself.
Sir, please. Now, okay. Yeah.
Okay. So, I'm sharing my screen, which will have Bappa's presentation here. Right. So, I'm sharing the screen. Bappa, you can see your first slide?
Yes, sir.
Yes. Please speak slightly loudly.
Yes. This was an 18-year-old male patient. He fell from height, around 20 feet height, from two-story building. And he presented to us 3 weeks after the fall. Okay, there was pain and swelling around the ankle joint. And next.
What happened in these 3 weeks? What was the management?
No, probably he has went to a quack and some
bone setter, traditional bone setter.
Yes, traditional bone setter, and some judiciary was done.
Dr. Hariharan is laughing.
Went to a quack.
Yes, it happens. It's rampant in certain part of India, including our part. makes things more
Still
complicated
there
for
was
us.
after 3 weeks there was pain and swelling, and patient was unable to bear weight, so he presented to us. Okay.
So now, what's your opinion, Dr. Hariharan? How do you tackle this?
Okay, now this was
assessment from your part, Dr. Hariharan. Assessment.
Yes, it's exactly the same as everything else. This, it's not looking at it on an X-ray.
No,
it doesn't look to be a very severely comminuted fracture, but I bet you if you got a CT scan, it'll show significant comminution, possibly medial comminution of the fracture. It's actually bordering on being a body fracture. It's actually quite proximal, although the distal end is definitely in the neck. There is significant incongruence in the subtalar joint, so I'm presuming it's sort of a Hawkins type 2 fracture, although we'll need to get a CT before we can justify that. But it is a salvageable fracture. If you looked at the AP view, you can actually see that the trabeculae are still there, and it's still hanging on to its vascularity, which is wonderful news after 3 weeks. Although you may not, it may still go avascular once you go back and then try and manipulate back. But you know, it's eminently salvageable, the fracture. But I will need a CT scan anyway. I'm slightly spoiled, but I will definitely need a CT scan for that.
Sir, actually, CT scan was done in this patient, but unfortunately, I don't have it.
Okay.
At present. And there was a lot of communication at the fracture site.
Proceed.
Hello.
Shall I proceed with the
Yes,
slides?
sir. Yes.
Okay.
So this was the 18-year-old patient, and we tried to salvage it, and this was done. It was quite difficult to reduce the subtalar joint. So we put a transcalcaneal K-wire, and traction was given, and subtalar joint was reduced, and rotation was controlled by rotation of the body fragment was controlled by this Steinman pin, and the fracture. Yes. Oh, sorry. And medial approach was taken. Medial malleolus was osteotomized, and fracture was clearly visible. Bone debris was debrided. Small bone fragments were debrided. Then subtalar joint was reduced, and then this Steinman pin was used to derotate the body fragment. After that, the fragment was reduced and held with a K-wire, and after that, compression screws were given. So,
okay. May I interrupt over here? Dr. Dibos?
Yes.
What's your opinion on this? You also get some complicated or rather late cases, maltreated cases.
Yes, yes.
So what's your opinion on this? Would you like to salvage this, salvage this ankle joint even after 3 weeks of this kind of
after
fracture?
3 weeks? After 3 weeks, there is less chance. There is chances of AVN. So lot of chances of AVN. So I will go for a medial malleolar osteotomy. Try to reduce it, fix it by screws, and hope
basically
for the
what he has done.
Oh, about he has
basically
done.
we agree with what he has done.
Similar thing I have done. The next case you will see, but that was a recent case. So after 3 weeks, probably open reduction he has done. Definitely, this is another type of method.
Comment from Dr. Hariharan at this stage about the methodology of thinking and methodology of procedure.
So the three things that have happened here, Dr. Bapaditya, one is the longitudinal height of the hindfoot has been lost. Okay, so there is plantarflexion of the body fragment. The second thing that's happened is there's a lot of soft. Yeah, you can see that the longitudinal height is decreased down. The body fragment is plantarflexed. Second is severe comminution. I'm not so worried about avascular necrosis. at this stage, because I mean, it would have occurred from day one. The die is cast on the day of the accident. So I'm not going to get, this guy is an 18-year-old, and I will make every attempt at salvaging this. The one thing that I'm not really sure of is, why did you need a medial malleolar osteotomy here? The fracture is almost anterior to the medial malleolus. And my personal view would be, I wouldn't need a medial malleolar osteotomy here. I think I would have been able to unpick the
This is
soft
the
tissues.
fracture area. If this is the fracture area, you would recommend
Yeah,
medial malleolar
correct.
osteotomy. This
If
is
it's
the
a
area.
body, yes,
Like
absolutely. And if
Sean
there's
Hindu's
like,
case.
that's correct. The first patient that was shown, that probably would justify it's a posteromedial injury. If you couldn't get to it using just a posteromedial incision, it's absolutely the right thing to do to take the medial malleolus down. But in this situation, I wouldn't add to the trauma of the existing scenario by doing a medial malleolar osteotomy. I think this would have been accessible. I think. I mean, you were there, you know better, and I'm sure you had your reasons for it. But I would try and avoid medial malleolar osteotomy. The one thing that I would almost certainly do, you used a calcaneal traction pin, is that correct? Did you use a calcaneal traction? Did you say?
Bappa, did you get that? Dr. Ghosh?
Hello.
Dr. Hariharan has a question for you.
You have to
You
unmute
unmute
yourself.
Okay.
Hello.
Could you please repeat?
Sorry, could you come close to your microphone and speak? We can barely hear you, sir.
Sir, would you please repeat your question?
Okay.
Have you done a calcaneum traction? That he is asking for that.
Yes, yes. It was difficult to reduce the subtalar joint, so a transcalcaneal pin was applied and traction was given. And
Okay. Okay, no, that's absolutely fine, because again, I would probably use a femoral distractor or a large Hintermann distractor to try and increase that space. It's not always helpful, but I think in this circumstance, it definitely is.
That allows back flexion of the talus.
Correct. Exactly right. So you're able to push the talus back into the mortise without struggling too much, because you would have distracted the space occupied by the dome of the talus. The second thing, sorry, sir, go on.
No, sorry, Dr. Hariharan, please finish.
No. Go ahead, Kushal. I don't want to hog.
Just to add to what you were saying, if you can use a Hintermann, the tail just flocks in, it just reduces very nicely. You don't have to use any violence at all.
Well, the plop-in is slightly doubtful after 3 weeks.
After 3 weeks.
Yeah,
yes.
that's okay. I mean,
it plops in acute case, yeah.
But
after 3 weeks, it gradually goes in, gradually goes in.
The second thing is, in a circumstance like this, rather than just using a medial incision, I would almost always use a 2-incision or a 3-incision technique. I would use a lateral incision because there will be a lot of fragments in the subtalar joint that you can take out through the lateral incision. And I've almost, sorry.
These are the fragments here.
Correct. You can see the fragments there, and you will have to take them out. Otherwise, your subtalar joint will not move freely after the procedure. The 3rd incision I would use is a posterolateral or a posterior incision, because I would almost always want to put my screws on the posterior aspect. Yeah. You can use the vertical limb of the extended lateral approach if you wanted to, but it's almost always in a delayed setting. I would use 3 incisions, almost.
So 1 incision here,
yeah,
1 there,
yeah, and one behind.
There.
Correct. I mean, that'll be my standard fare. I wouldn't attempt to try and reduce it without configuring it right, because if you fix the fracture in supination, the patient will come with a varus deformity. He will curse you every day of his life. Right. So that is really important. And from the point of view of the biomechanics, it really is important that you get impeccable reduction. As long as you're able to get the rotational component of the talus right, the x-rays may not look pretty, but I think you will win if you did that. If you've got a somewhat extended malunion, extension at the neck, you might get away with it. But if you've got supination of the distal fragment, you're in big trouble, because you're going to have a mid-foot, forefoot supination, and that is going to cause a lot of problem for the patient. Now, if you go to your fixation, did you use bone graft, did you say? Did
some amount was of compression was
Bone graft.
no
Did
bone
you-
grafted was low.
No bone grafts. Okay. So next slide is this. Could you elaborate on this slide? Bappa? Unmute yourself. Unmute.
Yes, after reduction, we found that subtalar joint was unstable. So we used a K-wire, temporary K-wire, to fix it. And we had some doubt about talonavicular joint. So we used another K-wire to fix temporarily fix the talonavicular joint. And for the final X-ray, a slab was fixed and K-wires were removed after food.
So have you got another X-ray once everything was removed, or is it?
No, sir.
Okay.
It's pretty recent, I think.
Yes,
the
this
case
case was done around
March.
5 weeks. Yes, 5 weeks, 5, 6 weeks.
In the lockdown period.
Yes, sir.
In the lockdown period. We are locked down, you know. So the comments from the esteemed faculty. Kushal, start with Kushal.
So I had a question for Dr. Hariharan. What's your opinion about anterior approach for these fractures?
I struggle with it because I don't have access to the subtalar joint. You know, what I would like to see is congruity in the subtalar joint as well as congruity of the fracture reconstruction itself. And an anterior approach simply doesn't allow me to go there. I mean, you know, there are people who you've used that approach and who'll use an arthroscope into the subtalar joint. I'd rather see it myself. And I've always been, one of the other issues is that you're going straight into the vascular ring over the dorsum, which has already been wrecked by the fracture, and you're going to strip it even more. I would prefer small incisions that I don't have to strip at all, but incisions, multiple incisions, medial and a lateral, or medial, lateral, and posterior. But that's my usual combination. I use all 3 incisions.
Would you ever,
Are you online or what?
Would you ever consider putting screws from the
Banerjee is online?
From the anterior aspect, Kushal?
Yeah, I would often use one of those HCS screws, you know, in the small neck fractures. Would you ever consider that? And
yeah, well, I mean, never say never. But what I've gone away, I mean, I've actually gone away from using many screws. I use the dedicated talar neck fracture plate that you get in many foot sets, and they are wonderful devices. They are locked plates, and they fit in beautifully into that curve of the talar. So I've gone away from it altogether. I've used the plate and the screw. I've used the posterior to anterior screws and the plate, because I think it does require some fairly secure fixation, because it does tend to either break out or rotate out on occasion. I've seen that happen. It tends to displace. What you can see there now is exactly what an anterior to posterior screw does. If you looked at the fracture, again, Dr. Bapaditya, these are, I'm not being critical, I'm just making observations. You know, we're all learning from this. Please don't be disheartened. This is an extremely challenging patient, and you've done well to do what you've done. If you looked at the AP screws, that is exactly what happens when you put an anterior to posterior screw, is that it extends the fracture, dorsiflexes the reduction. So you could have a beautiful reduction and you've held it temporarily, and then you put screws in, and the natural tendency for the screw is to dorsiflex the fracture, and you've got an extension malreduction at the fracture. And, you know, that's sometimes is inevitable, because the axis through which you put your screw will naturally do that for you. Whereas if you put a screw from posterior to anterior, the end of the screw is often in the plantar half of the talar head, and it will not dorsiflex the fracture. I mean, I've never seen that happen from a posterior to anterior screw. If you looked at the intraoperative picture, can we go back to the intraoperative picture?
Sure, sir.
So if you looked at it there, you can already see that the one screw that you've put in has already extended the fracture there. If you follow the talar dome outline dorsally, instead of smoothly flowing up there, you can see how that there's a steep angle, like a V angle there, which means that the talar head is extended there. So that has already happened with just you putting the one screw there. And so that is the reason why I steer clear of using anterior to posterior screws. And also, that probably wouldn't have happened if you had a distractor on, because the dome will be comfortably sat in the mortise, and you probably wouldn't have had that problem. I'm totally against. So what that big Steinmann pin is doing is it's taking out a portion of the articular surface of the talus and of the os calcis, and that is something that I would really not do. I would prefer to avoid that. What I tend to do, again, the advantage of a posterior incision is you can put a Steinmann pin from posterior to anterior and joystick the talus any which way you want. It's actually much more in the axis of the talar dome. If you wanted to joystick it, it's actually far easier to do it from behind. You can varus, valgus it, you can dorsiflex, plantarflex it much easier than you would with. Because if you looked at where your Steinmann pin is, if you wanted to dorsiflex that talus, you can't, because your Steinmann pin will hit your tibia now.
Yeah.
Right? Yes. So you can't pull that towards the posterior to try and dorsiflex the talus anymore, because you've automatically the skin over the tibia, the tibial is anterior, tendon and everything else is in the way there, and it automatically stops you. So you're actually using a system that's not a very efficient lever.
And just to add to that, and one of the interesting, was listening to one of the talks by Dr. Van Dyke, and what he said was the anterograde drilling, right, is actually very harmful for the talus. Because what it does, once you take the pin out, the cartilage acts as a valve which closes off.
Yeah, and you get a cyst.
Yeah, the underlying cyst develops, and that leads to an osteochondral lesion and arthritis in the long run. So there's another reason why we shouldn't be putting anterograde pins anywhere, actually, for that matter.
I agree.
Abhijit is still there. Abhijit, Dr. Abhijit Bandyopadhyay?
Sir, he is there, but I think.
Can we have his comment on this?
Dr. Bandyopadhyay. Dr. Bandyopadhyay. I think he's
Let's
there.
pass on to the next slide. Next slide here. Oh, that was the last one. So this is about 3 months follow-up. Oh no, less than 3 months. 6 weeks follow-ups, no?
6 weeks follow-up.
What's your plan about rehab? Bappa, what's your plan about rehab?
Yes, sir. I have already removed the K-word, and
Both of them?
Yes, both of them.
2 K-words removed, and then?
And the patient is supposed to come within 2 days after for checkup, and I would do an X-ray, and if everything is satisfactory, then I would start partial weight bearing.
How about the movement of the joint? At least the ankle joint. You have allowed the ankle joint to move?
Yes, yes. I have allowed movement in the ankle joint, and I have removed the K-wire and plaster 2 weeks back.
Okay. So we have come out of this talus case as well. So we have covered talus and Lisfranc's twice over, and 2 different scenarios of those, and the calcaneum also. So I think it's time to sign off, because there are other webinars going on. There is another web on bone tumor going on from about 8:30, I think. So from here, I hand over the mic to our organizers, Mary and Oakard, for their finishing comments, and then we will sign off. But before I sign off, it's a privilege to thank all the faculty who took their precious time out of their busy schedules and enlightened us, especially Dr. Hariharan. And as you know that IFASCON was to happen in Kolkata this year.
I know.
It couldn't be. It had to be postponed by some virus.
I was waiting to eat
we were waiting for you
puchkas
also.
and dum aloo, and you know, I lost the chance.
I was the scientific chairman this time of this whole conference, so I extend this invitation for next year also. We'll have the.
It's my privilege, sir. It's my privilege.
If Corona permits, we'll have your conference in the same
definitely.
dates. Yeah, and I would like to.
I've learned so much from it
physically
too.
over here.
I've learned a lot. That's what I find with these webinars, that you know, it's not just
about,
the people who are listening who learn. It's a fact. I mean, I've learned so much just from looking at these terrible cases. You know, hats off to you guys for doing what you're doing. It's remarkable, really.
Thank
and
you.
I have a lot to learn from you.
Yeah, that's a very encouraging word from Doyen, who is in there for decades practicing this, and it's a enlightening 3 hours. 3 hours have passed like a jiffy. We don't know when it has passed. So 3 hours, very enlightening 3 hours, and very interactive as well. So with all these words, I'm signing off. And
thank you, sir.
The last
Thank you
word
very
will be
much.
Spoken
Thank you,
by,
all of you. Thank you so much.
Thank you, Dr. Kaur.
Okay, thank you. See you here, 2021.
Thank you.
এন্ড করছি
করে দে।